country, and we once again thank you very much. We also thank the past members who all contributed to the functioning of the health sector throughout the partnership and the engagements we had. I ask for indulgence to the proposal that we want to put forward. I wanted to give some background, and then because we have various directorates, the health sector is one of the biggest and then most complex in this country, so that each of them will delve further into their activities, if that is okay.
That's okay. As I said, the floor is yours. You decide on how you want to do your presentation. After that, honorable members will have the time to intervene.
Thank you. The Ministry of Health has the mandate to provide health services for the people of this country, both preventive and curative, and there are various components to that. The ministry is headed by the Minister of Health, and we have two permanent secretaries. Permanent secretary, typically if it's a technical person, we have a technical permanent secretary and permanent secretary admin and one, but typically we have PS1 and PS2. We have our PS1 here. PS2 has recently been moved to the Ministry of Trade. We've not gotten a replacement yet. We have two deputy permanent secretaries, one admin and finance and the other technical. Thereafter, we have the other cadres, just as we have in other ministries, assistant secretaries, principal assistant secretaries, and so on and so forth. Now, the ministry is one of the largest, I have said, as I have said earlier. We have 9 core directorates, and it is important, some of you know them, but just as a reminder, we have the Directorate of Nursing and Midwifery, Directorate of Public Health, Directorate of Medical Services, then we have the Directorate of Human Resources, another of Health Promotion and Education. We have Directorate of Planning and Information. We have that of Research. We have one for National Pharmaceutical Services, and we also have National Public Health Laboratories. So these are the 9 directorates, and each of the directorates, so to say, has a number of programs under them. So the programs are the implementing wings of the ministry's activities. 2 new programs that came into being recently, which are of very big importance, is the Cancer Control Program. Of course, you all know the rising incidence of cancer. So recently we have the Cancer Control Program introduced. The other one is the Hepatitis Control Program. Gambia has a high rate of hepatitis B positivity, and we thought it is important to introduce hepatitis control program in the Gambia. And we have these 2 new programs that are being strengthened now to enhance the functionality, and they are under the Directorate of Health Services. I'll give you a little background. The Gambia is facing a double burden of diseases, as the mortality and morbidity from non-communicable diseases, called NCDs, are on the increase. NCDs like cancers, cardiovascular diseases, chronic respiratory diseases, diabetes, and injuries are contributing to increasing mortality, accounting for 34% from the 2014 data, and 32% rather, and then 34% in 2018 of all deaths in the Gambia, with cerebrovascular disease accounting for the highest proportion of NCD-related mortality, which altogether is 14%, followed by cancers, 4%, chronic respiratory diseases, 2%, diabetes, 1%, and other NCDs accounted for 12%. The risk factors for NCDs and its prevalence include harmful use of alcohol, 2%, unhealthy diet, tobacco use, physical inactivity, obesity, and air pollution. By way of statistics, maternal mortality in the Gambia, though reducing, is still unacceptably high, estimated at 289 per 100,000 live births. This is data from the Gambia Demographic Health Survey 2019-2020. Low coverage of life-saving obstetric and neonatal emergency care contributed to maternal and neonatal deaths. The majority of maternal deaths in the country are because of avoidable direct obstetric complications, including hemorrhage, hypertensive disorder, and severe anemia. The high fertility rates, gender inequality, gender-based violence, malnutrition, and low socioeconomic status made the situation worse. Progress has been made on only one of the childhood health indicators. Childhood mortality rate 15 per 1,000 live births in 2020 compared to 20 per 1,000 live births in 2013, so there has been a reduction. According to the HMIS Service Statistics Report 2020, stillbirth is at 32 per 1,000 live births. Malnutrition continues to be a major health problem in the Gambia. However, declining trends have been observed over the past few years, from 25% stunting, 12% wasting, and 16% underweight in 2013, to 18%, 5%, and 12% respectively in 2019. The previous figures are for 2013 GBHS, and the last figures are for GBHS 2019 to 2020, which has shown some decline. Distinguished honorable members, our work is guided by health policies and strategies, and which are equally based on 6 building blocks, now as recommended by the WHO. The first one is governance. The second, health infrastructure. The third, health products and technologies. Fourthly, health information system. Fifthly, service delivery and health financing. Sixth, health financing. The ministry and the government have been working on all these aspects. When it comes to health governance, we have had quite a lot of restructuring in the health sector, from the central ministry level to the regional levels. Allow me to say that at the regional levels, we have regional directorates. There are 7 of them. In the health sector, we have 7 regional directorates, 2 in the Western region, that's Western 1 and Western 2, 2 in the North Bank regions, that's North Bank West and North Bank East, and the others are for LRR, CRR, URR, making 7 health regions, and we have 7 regional directorates with functional directorates that are based in the regional capitals, where they have their team of health professionals manning the health sector at that level. With health governance, we've tried to improve on transparency and accountability in the health sector as much as we can, to reduce wastage and to close the gaps. This has been very important because what we inherited was very, very challenging, and we realized that if we didn't do as we did, ensuring accountability, transparency, and efficiency, the health sector wouldn't move to the level that we wanted to move. Thereafter, we can divulge more on those steps that we have taken to ensure accountability. One of the very important, I think, positive result yielding strategies we have done is to insist that participants in our activities are paid directly into their bank accounts to ensure accountability. Where they do not have bank accounts, we pay them using mobile money. This initially wasn't very popular. There was quite some resistance, but eventually that is what we are doing, because we want health officials to keep away from receiving impress to go into the fields to be paymasters and paymistresses. We think that should be left with the accountants and the finance people. and that now is helping us ensure more and more accountability. And we've improving on our governance structures, and at some point during the deliberations, you'll also be told that we actually want to bring in what we call performance management system throughout the health sector, so that people will work according to their TORs, and this will be monitored so that people who perform well will be rewarded, and those who do not perform well will be reprimanded as they are supposed to be. Because we also believe that without this, things that are supposed to take 1 week may end up taking 3 months, because whether work is done or not, people get paid. And we thought that is not good enough, and we are instituting, with the support of our partners, World Bank and WHO and other partners who are very enthusiastic with this initiative, performance management system. Health infrastructure. The health infrastructure in the country, what we inherited was a very difficult situation. We inherited dilapidated infrastructure. We inherited, in some places, structures that were virtually collapsing, equipment that were obsolete, and so on. So we started embarking on upgrading, renovation of health facilities across the length and breadth of this country. And so you have all been seeing what is happening in the Edward Francis Small Teaching Hospital and then the polyclinic. This includes expansion work, building of new structures, and the entire facilities are going to be renovated. This extends to other facilities, and construction work is going on. New health facilities are coming on. The chief amongst them being the new emergency treatment center at Farato that's been built with support from the World Bank. This is a 100-bed modern facility which is going to have 20 standard intensive care beds amongst the 100. And the site is also going to have a new national public health laboratory, a new national blood bank, and then a new conference center for the Ministry of Health. These are just examples of the infrastructural development we're doing. At some point, one of the presenters will list the rest of them. Health products and technologies, we all know Gambia does not produce any of these items that are used in the health sector. Somebody looked at the statistics, looking at the drugs and the other consumables that we need in the health sector. He put it at 400 items are needed. And each of those items is important, and they can hardly substitute each other. And none of those items is manufactured in this country. They are all imported. The consequence is that the issue of poverty comes into play. Gambia is a poor country, but even with our poverty, we say if a patient needs adrenaline in Gambia, it is the same adrenaline, a similar patient needs in the UK or anywhere in the West. But we do not manufacture them, we do not produce them, so we buy them at higher cost. Suppliers bring them, pay custom duty and so on, transportation, and come and add their profit, and we buy these items at that high price, even with our poverty. But apart from that, the supply chain system, the problems are there, especially when it comes to international trade and shipment. This is manifested in the challenges we have when it comes to the drug supplies as we speak currently. But fortunately, the supplies, the drugs have started to come. They are offloading quite a lot of containers now. The Director of Pharmaceutical Services is happy that a lot of life-saving drugs have started to come into the country. Health technology-wise, a lot of equipment are being procured. We procured a lot of equipment over the past years. This is just a recap. They will tell you the details. We also train in more and more people with regards to this equipment. Honorable members, you'll be very excited to know that the Gambia, before now, they didn't have a clinical waste treatment system. Clinical waste from hospitals, wherever they are in this country, they are gathered and taken to the dump site and dumped there. There are times that you see human parts, at the dump sites, which is very risky for the population, and the rain washes this into the water bodies. But fortunately, we will very soon launch a very robust clinical waste management system. We've got a huge machine at the Clinical Waste Treatment Center that is being built with the support of the World Bank, and also the Farato farms there. There's a site for that. And that is the EcoSterial 250, which they are testing now. And then we've already gotten the EcoSterial 75 at the Edward Francis Small Teaching Hospital. These employ a microwave system to microwave the clinical waste to become harmless, whereby they can then be dumped, discarded, or used for other purposes, because we are told that even the waste products now can be used for other things. In all the regions now, for the first time, we have modern containerized incinerators for each region. That's a big plus for clinical waste management in this country. We've never had before. Health information system is very important, as you've been told, in the sense that without information, then we are working blindly. And then these days, we talk about evidence-based systems. Typically, we don't want to work on anecdotal evidence. We want to work on issues when the evidence is there. And we want to be able to monitor based on the evidence, and also evaluate at the end of interventions based on the evidence. So without the clinical information, health systems certainly will be impossible, and focus on what is important will also be a big challenge. Now, for health information system, we started launching various systems, we'll be told in the presentations also. We started working on the electronic medical record system, which is very, very important, because with that, people can be seeing their records. We will not hear of stolen files or missing files or misfiling. And people can have their medical records, even if they were seen in Basse. They come to Banjul, they don't need to carry papers or anything, any stuff. All they need to come to do is to get to the health facility, and then the doctors will click in and then see the records and what was done for the person in Basse. Also, we're working on an electronic logistic management system. That is also very important. So that is a big plus. Mr. Sabali's baby, and the Global Fund is supporting with that. Now, this will enhance proper recording of all the health products. We've always been lamenting that when a tablet of paracetamol leaves the central medical stores in Kotu, we should be able to trace it to a patient anywhere in LRR or URR or anywhere in Gambia who consumed it. Without that, it will be very difficult to monitor drug usage in this country. People can speculate that items get missing, there's pilferage, which we don't have evidence on. But to close that gap, if we are able to monitor for how many people was paracetamol prescribed in a particular facility, using this logistic management system, that will be very good. And it is just not the drugs, it is even other health products, and equally speaking, the equipment of the Ministry of Health. So that's very exciting. And the electronic human resource system also, we are working with partners to institute that. So a lot is happening when it comes to standardizing, modernizing the health information system in the country with support of all these gadgets. Service delivery, we've ever since had challenges in service delivery. We inherited difficult circumstances, even though there has been a lot of improvement. The referral rate from the Gambia is reduced now for the mere reason that we've now gotten more and more specialists in the Gambia. We recruited specialists from Cuba who have come. We've got now more Gambian specialists, and we have also recruited specialists from the sub-region. We have, I was recently informed, number has got into 15 very senior doctors from West Africa who are here at the Edward Francis Small Teaching Hospital participating in postgraduate training of our young Gambian doctors. So by so doing, they equally provide advanced clinical services. For that reason, mortality itself is going down, especially in pediatrics in the Gambia. We have very seasoned, experienced clinicians who are now in country and working with our team to reduce mortality. In the same vein, it is very satisfying for us to also let you know that we have now started specialization training for doctors in the country for the first time in the history of this country, which is a big plus. And a lot of young doctors are passing the exams, and they, inshallah, will become consultants in the country, specialists in the country, like some of us here, without even stepping out of the Gambia. I think that is a big plus that is happening. So service delivery improvements are there with provision of more and more equipment. We of course there are still challenges, and getting all the complements of specialists in a country is not an easy thing, because medicine is very, very broad with many specialties. But there are plans as to how we hope to work on that. Part of that actually is bringing in more specialists. Two very important aspects we want to institute in the clinical area is kidney transplantation. We're working with some partners so that we can start that here, inshallah, in some few months. And the other one is open heart surgery. Quite a lot of patients who require referral are patients with end-stage renal disease who need kidney transplantation, and those with heart problems who also need open heart surgery, and we are unable to do those here. So we are endeavoring to ensure that we get those. So we still have challenges with attitudes. Some of the problems are with attitudes rather than with resources. People getting to work on time, and when they are at work doing what they are supposed to do. But the processes are going on. But with the performance enhancement and performance management system, we believe people's attitudes will change, and also that will have a positive impact on service delivery. Health financing is another very important thing. There are experts in the room here who will talk to you. The Permanent Secretary will talk to you with regards to the budget, and Mr. Jaju and team, Director of Health Planning, the health financing aspects will also be discussed. But I think when it comes to health financing, one very important plus for the Gambia is the introduction of the National Health Insurance Scheme. We believe that's going to be a game changer so that people do not have to suffer when they go to any health facility in the country, both private and public, when they are part of the National Health Insurance Scheme. And everybody will be a part because it is mandatory by law. And we want to use the opportunity to thank the committee, the House Select Committee, for the hard work that they put into the development of that act. The bill came here and they went back and forth and had a retreat and scrutinized. I'm sure we have experts of that, in this room here. But we think it's a big plus. We have launched. The board has been launched now. CEO has been appointed, and actually they've started work. They want to inaugurate to start recruiting people, inshallah, sometime next month. The insurance scheme will be launched itself, and people will be given insurance cards. So they are doing the structures now, so that we can work on that. And I think that's going to be a game changer for the health sector in this country. In a similar vein, we have also started the electronic birth registration system, which is also a big plus for this country. Birth certificates now will be in the electronic form, and the data will be captured, and they have collaboration with the immigration department whereby there will be linkages so that people will not have issue of fake birth certificates anymore, and anywhere people go to, there can be authentication of the birth certificates. Yeah. At this juncture, distinguished honorable members, I would like to pass it to who's this coming? Yes.
Yeah.
You, Jibril?
Yeah.
Okay, to Director of Health. Director of Planning and Information Center of the Ministry of Health to take us through. Thank you very much. Thank you.
Thank you very much, Honorable Minister, for the overview of the health system and the committee members, honorable members. Having provided a very big, comprehensive overview of the health system, most of the issues he has already touched on. I'll just graph through, but you realize that Honorable Minister have foresight information and have the vision of what actually we need to do as a health system, and what they are currently also doing. So I'll take you through the outline. It's a summarized version. As he rightly said, we have we are a big ministry, and we have 9 directorates with over 30 program units, and each of the program units are specialized units doing their own thing on a daily basis for the entire year. So if you have to bring everything here, Baba will be here the whole day. But we're taking the high level of your interest to show you how we are faring and also what transpired last year. So the Honorable Minister has mentioned the 6 building blocks. So we try to organize the presentation around these building blocks. We have the governance, we have the health financing, health infrastructure, health products and technology, health information system, and service delivery. So to begin with, the Ministry of Health has just finalized the policy 2021-2030. And in that policy, we have our vision, we have our mission, and we also have our goal. And the overall mission of government is to actually have a healthier and more productive population through universal health coverage. And this universal health coverage is what actually the government have launched, which is the National Health Insurance, which the minister has also mentioned. And the mission of the ministry: create an enabling framework for full participation and provide leadership in the integrated delivery of quality, effective, and responsive health service delivery. So the ministry going forward will want to encourage partnership. In fact, that's what this policy is all about. Partnership in service delivery, partnership in making sure that resources are adequately mobilized for the Ministry of Health, for us to be able to actually deliver healthcare service delivery. So we realize that all of us as stakeholders are very important in the implementation of the new health sector policy and as well the accompanying strategy plan. So the goal is to also provide quality, affordable, and accessible healthcare service for all in the Gambia. So this is also premised on the expansion that the ministry is doing. You cannot provide accessibility if you want to maintain the same status quo, because we all know in the rural areas, transportation is not as easy as in the greater Banjul area. People still trek to go to access health facility. People still, board on horse cars, to go to health facility. So in order to increase accessibility, we have to expand as well. So in terms of our structures and in terms of the service delivery models, so it is on the vision of the ministry that, going forward, we want to expand on the primary healthcare module by making sure that at least in every village we have at least a trained village healthcare worker. Currently we have a cluster of villages we call the circuits. But as we grow, we want to also come down from circuits to village level, so that at least at every given village, somebody can be trained to be able to at least give advice on the preventive component of certain diseases. So when we look at our new policy, it has 10 priority areas: quality and equitable essential healthcare services. This is very key in the sense that we as a ministry have a social mandate, meaning we need to treat people, equally. But you cannot treat people equally who also have different health conditions. So that's why we have here equity. Equity here is somebody who needs paracetamol, give the person paracetamol, and somebody who needs amoxicillin, we give the person amoxicillin. So you cannot treat every individual the same way. So that's why the ministry certifies that our number one priority is to make sure that we provide the need to every Gambian who is living in the Gambia based on your need. We also have maternal mortality. Minister has mentioned the figures. They have drastically come down. In fact, in our institutional delivery, the data that we are getting is around 123 per 100,000. But the DHS that has ended 2019-2020, it has pegged it at 289 per 100,000. From 433. So there has been a drastic improvement, across in this particular area. We also have communicable and non-communicable diseases. Minister has mentioned we are shifting as a country from communicable to non-communicable diseases. So which means now we also need to change, and it is very expensive to actually tackle communicable diseases. And when the peers tell you the figures around hemodialysis, how much we are spending, for example, on hemodialysis, and the number of patients, you'll be very surprised. So which means the ministry is also very much cognizant of the fact that communicable and non-communicable diseases, especially non-communicable diseases, are on an increase. We really have to, make it a priority to tackle them early and to employ the preventive mechanism to make sure that we handle them. And also the next priority is the resilient and responsive health system. How do we make sure that our pharmaceutical sector is well equipped to be able to respond to the need? How do we make sure that the lab is also up to date and will be able to take care of the major laboratory tests rather than referring, for example, to Senegal for tests? So how do we make sure that we have adequate human resource? So this area talks about human resource training, capacity building, the standardization of the laboratory, and the minister have also mentioned the work going on in Farato, which is going to be history and a legacy for all of us, because there is fantastic work going on, but there's probably the entire combined ICU bed in the public sector will not match what we are building in Farato. We'll be having almost above 20 ICU beds, that will be available for the Gambia. So we also have integrated health information system and health research, because the decision that we are making has to be evidence-based. We need to get the evidence to show the people that we are making progress. We are making progress in terms of our healthcare service delivery. Some of our interventions are probably not short-term. People may not feel the impact now. We are not like when the prices come down, people realize. Our intervention will be felt over time. When independent institutions do their own surveys and realize that there's improvement in the health sector. For example, the recently concluded DHS. The ministry don't have control over DHS. DHS is done by a separate institution, which is GBOS. And then they have come and vindicated the ministry that you are doing a fantastic work, because the indicators are A, B, and C. So we also have environment, health promotion, and social determinant of health. But these social determinants have an influence over the non-communicable diseases. So that's why the ministry take it as a priority. And the financial risk protection, this is where NHIS is. The vision of the ministry is to make sure that people don't suffer catastrophic health expenditure. People don't actually think about money when they fall sick, you know, so we are advanced in this. And also the continuum of care at tertiary level. As much as the country is a developing country, our focus should be on the preventive component, but we should also not neglect the tertiary care. There's few individuals that may need specialized care. So that's why I said, you know, equitable. So if you want to discriminate and say, okay, because the country is a developing country and most of the disease burden are communicable disease, so you want to put more effort. So you still disfranchise the few individuals that need actually, you know, advanced medical treatment. That's why we have this as a priority. We also have enhanced governance for service delivery, you know, which deals about restructuring, putting up capacity within the central level so that we'll be able to deliver healthcare services. And last but not the least is the partnership, which deals with partners the ministry is dealing with, which are the donor partners, the partners ministry is dealing with in terms of legislative, you know, reforms, which is the National Assembly, and partners between the Ministry of Finance and other ministries, and also CSOs and NGOs. This helps, and the community as well, because whatever intervention we are putting up is for the communities to actually enjoy. So that's why we have a 10th priority area, which is on the partnership. So diving through some of the activities, implemented activities, to give you an overview for the 2021 is the development of a health policy 2021-2030, which is before you, and also the development of a strategy plan, you know, to give direction to the ministry in terms of what we actually want to deliver. And also, you know, people always said, you know, the quality of care. You know, the ministry have a tool that actually monitor the quality of care that is delivered across the country and per tier, from the health post to minor health center to major health center to district hospital to the teaching hospital. So we have, you know, we've done a successful work on that, and we're also now registering and standardizing the private health sector. As per the Medical Service Act, the Director of Health Services, you know, with the approval of the minister, is mandated to actually register and launching the private health sector for them to provide. The private health sector here, we mean both any structure that deliver healthcare in any form, physiotherapy, you know, lab, clinics, hospitals. As long as you are providing a form of healthcare, you are mandated to be lancing. And all these, you know, reports have been validated. The study plan has been validated, and we also have a standard 2021 statistic report as well. And also the, you know, as part of the governance, minister has mentioned the equestrial machine. The ministry has procured waste management materials and distributed them across the country, and in 2022 it is also ongoing. So now the issue of you know, this year, currently there's a meeting going on to set up a health, you know, a regulatory committee, you know, to regulate, to actually get into lancing the private health sector. So in 2021, what we did was the ministry did an assessment of all the private health facilities using a standardized tool. So each of the facilities that met the requirement to be lancing, they have to submit an application, a formal application, which has to go through the Director of Health Services for approval before you are actually allowed to operate. But the ministry is also negotiating to see how they can put a licensing fee for the operation of, you know, of each of those facilities. We also have, as a planned activity under governance, is review and update of the health sector emergency preparedness plan. It seems we are, we are forgetting. COVID-19 is still with us, and we passed through a very difficult moment. And now the ministry is also reviewing some of the successes, the challenges during the COVID-19 response, and coming up with a more comprehensive emergency response plan that will at least make the Gambia more prepared for both reimagining diseases and also pandemic and diseases within the sub-region. We all know that the sub-region is very vulnerable to diseases of public health importance. And one of them is meningitis, and we all know that Gambia sits right on the meningitis belt. And we need to prepare Ebola also. We are within the region that is also very susceptible to Ebola as well. So we need to get ourselves more prepared to be able to respond to diseases of public health importance. So the strengthening of the International Health Regulation 2005 implementation at point of entry is ongoing and is planned for upgrading, and the Directorate of Public Health is working very hard to make sure that these issues are done, and also incorporate IHR 2025 into the reviewed public health bill that probably will get to you at some stage during your time. And some of the activities briefly, is the NCD strategy plan. When you develop an overall policy, you develop an overall health sector strategy plan. So you get down to smaller level implementation, because the health sector strategy cannot capture all the interventions in health. So it looked at the higher level impact intervention. So the smaller level and disease specifics are developed by various programs, and one of them is the NCD, which probably will also His Excellency will be launching this strategy plan, because NCD are a cause for concern for the ministry. The cost is so high in terms of treatment, so people need to be aware to take health into our own hands and promote physical activities and also good health behavior. So that has been costed, and then ready to be operational. The essential healthcare package also has been costed now, and the tertiary level is also costed and validated. We also do what we call national health account to generate. It's a special study that you do to generate evidence to know how much is actually spent in the health sector. The 2016-17 is out, and currently we are analyzing the 2018-2019, and we will next week release the preliminary report for 2018-2019 and kickstart the 2020-2021. And I think it's important that National Assembly members also know how much is invested in health. This is a special study that tells you globally in the country how much has come into the health sector, both from donor side, from government, and from out of pocket, and from insurance. So it's a special, interesting study that we are very much interested as a health sector, because people would say investment is going into the health sector, but how much is it compared to other countries? How much is it compared to other countries? And what is the standard giving, for example? So consistently for the past 10 years, we have been having between 7 and 11% in terms of government, support to the health sector, which is between 8 to 4% below the Abuja target. So that's it. And we are, to support the National Health Insurance Authority, we have a plan to conduct willingness to pay. We have consensus around this particular activity. EU is interested in supporting with the TA, and WHO also have interest. So we will finalize with also the World Bank to see how we actually set up this study. But this will give the minister the opportunity to actually know how to set his premium in consultation with the Minister of Finance. So there has to be evidence that people are willing to pay this much to be enrolled into the health insurance. So this activity is high on, and very soon we will kickstart. So on the health infrastructure, currently last year His Excellency inaugurated 5 new health posts across the country, and we also started the construction of 8 treatment centers across the region. We've also, that's the Kafuta, Bansan, Sabi, Yorobao, Njaba, Kunda, Kanuma, Soma, Palamandi. These are the treatment centers as a result of the COVID-19. We also have the refurbishment of 9 isolation centers in the health facilities. We also have construction of new health facilities in Chisemajau, Mankamankunda, Salikenye, and Kiangjali. This is part of the expansion of the ministry to make sure that I make health facility, healthcare service delivery accessible. And we also have construction of a new MDR ward at New Yundu. Because when COVID-19 hit, we were not having a facility to hold such an infectious. We have a facility to hold such infectious disease, but it was for TB. That's the sanitarium. So, but then we have to, evacuate the TB patient and they use that facility for COVID-19 before the government getting demand ready for use. So, but we are also now building a new one at New Yulu so that we can also have, a TB patient use it, especially the MDR TB patient use it. As we still have a sanatorium on standby for any other, outbreak. So we also have a refurbishment of Edward Francis Small Teaching Hospital, and the polyclinic is ongoing, and also construction of a new health center at Jab that has started now. The past 2 weeks, they are on setting out, and it's going to be a major health facility to actually cut the referral rate, to Farafenye or to Kuntauru or to Bansa. So, the work is high on. It's part of the expansion we are actually doing. So we also have the renovation of Kuntauri Health Center and construction of National Emergency Treatment Center at Farah. So there is, this one has started last year, and then work is in progress. So the planned activity in terms of infrastructure expansion is we are planning to have 11 health posts, to be built, refurbishment of Sukuda, Fayukunda, New Yundum Health Center, as well as refurbishment of Nauderu, Daru Rilwan, Ker Ardo community clinics. We also have construction of ambulance set and restroom across the country. We also plan to do refurbishment of Biam General Hospital, Brikama Bar, Brikama, and Basse. But assessment is almost 95% done for Brikama and Basse. So there is advice that the cost of refurbishment of Brikama and Basse may be more, so the bank is probably thinking that we should have a new facility for Brikama rather than refurbishing Brikama with a high cost. So it's better you build a new facility for Brikama and expand it, and also build a new facility for Basse, which can be a regional hospital. Yeah. So that's the vision of the ministry, is to have at least each region to have one regional hospital. Yeah. So there is.
So in that vein, currently we actually looking for land for the Brikama one and for the Basse one. The current locations are very congested, highly congested. So we identify some sites we are working on that. So those are very big processes. So Basse is going to get a new health center and Brikama will open before it gets anymore.
Yeah. So thank you very much, Honorable, for the update. So going forward quickly on the health information system, we also do what we call client satisfaction survey to also see how people are perceiving our service delivery and what they want, and what's their advice towards that. So these are some of the issues that are going on. it is already been implemented, but we have the draft report is shared with the bank for review. It's supposed to be shared this week, before the end of this week. So we have, the HMIS team is doing some analysis. So once it is done, it will be shared within the team, the Ministry SMT, and then we will also have the report uploaded on our website as well. But we are now finalizing the analysis of the client satisfaction survey report. And this is about health information system. The ministry has a very interesting and a very robust system that collects data at the facility level, from facility to the regional level to the central level. So at every given time, we'll be able to tell you how many cases or how many deliveries each of the facility in the Gambia, has actually delivered. So we have those information. They're very interesting. So under the health information system research component, we still have we have conducted some brief assessment. One of them is the rapid excess mortality assessment for 2018 to 2020. And we also have conducted a COVID-19 vaccine hesitancy study, also was conducted. Because now all over the world, people are now moving from the initial phase of the pandemic now to the enforcement of vaccine. So now it's vaccine passport. If you want to suffer, go with your PCR. Most of the countries now, in fact, even with the PCR, you go through difficult procedures. Even with the PCR, you go through difficult procedures without any vaccine. So it's important that the Gambia also encourage, National Assembly members also encourage people to actually come out and get the vaccine. But it also will give the country a good name. If the coverage is high, probably the travel restrictions for citizens from the Gambia may also reduce. Understand? So and then that's what is coming. In some countries, if you with the PCR, you don't even enter. They will ask you that you must have to get your vaccine. I think you can even ask some of your members that went to Nigeria. It's very important. You must have to be vaccinated. So this vaccine hesitancy study was conducted by the ministry to see which strategies to use to at least convince people to actually take the vaccine. We also have the rapid retrospective assessment of mortality in the Gambia for the period January 2016 to 2021. This was also done, and the report and the results are disseminated on the 14th of June. To give us an overview the impact of COVID-19. And we also have a population-based age and gender stratified zero survey study also conducted in the Gambia. And now we have developed a health research agenda, and last year, and it was launched in 2022. So these are some of the planned activities for health information, including research, development of observatory, HMIS data verification, data quality review meetings, and also printing and distribution of COVID-19 SOPs and DOR, and development of a legal framework for health research committee, and to establish a functional health research committee, and to operationalize national health research agenda, and so on, and to conduct an equity study for maternal child health indicator using the PASS to DHS data, because all these are actually important. But the drive of the health sector is equity, not equality. You treat people based on their need. I don't need any surgery. So if you make surgery available for me, I will not take it. Well, I don't need it, for example. Probably I need anti-cold or something. So that's the focus of the health system. So they are, although small, but we can make them available. These are just quick, some of the indicators the Honorable have mentioned. They are in terms of institutional deliveries. Now the policy of the ministry is nobody should deliver at home. That's the policy we have. Zero delivery at home. Because the cry of maternal mortality, the cut down can only be attained if we get people delivered in our facilities. So you can see the decline is in maternal mortality can be also be related to the high delivery rate. So if we get more people delivering in our facilities and getting to our facilities also early, you know, not when when they start seeing the danger sign, but when when they start seeing mind sign, getting to the facility is very helpful. So our delivery rate is now at 97.9%. You know, which is very high, but our intent is to have 100% so that we can reduce maternal mortality. You know, yeah. So some of the indicators are here, but probably we will, you know, the secretariat here will make this PowerPoint available for you. These are some of the activities as well implemented in 2021. I'm sure those from URR, North Banks, East and West will every year we conduct what we call mass administration of malaria. How do we call them? Seasonal malaria chemotherapy. You know, it's an activity that we are implementing to fast track our malaria elimination drive. And we also conduct what we call indoor residual spraying in all those facilities. And we also do what we call mass bed net distribution. So currently, that's done every 3 years. So currently, I'm sure you must have seen our volunteers visiting your various houses to register the number of people that should get bed net. But last year, we did what we call drug administration to give under 5 kids, anti-malaria, Fancida, so that they will be able to build resistance to malaria. And we also conduct what we call community-based surveillance, and we have what we call community, this also activity is very important. Fumigation of premises, based on demand, like the big house, State House, AfriCell headquarters, Central Bank, Ministry of Foreign Affairs, Army headquarters, and also fumigation at the National Assembly. That is your own place here, and also they also support Edward Francis Small, to fumigate the place, especially the dead bodies, and also the routine distribution of waste management materials, and also screening and certifying food vendors as well, because we have the lab. Unfortunately, the lab is not like the Ministry of Health. So some of these food vendors is Ministry lab that actually screen and certify them to be able to actually sell. That the Ministry, as part of its partnership, as I said, our goal has to also train 160 people outside of the Ministry on waste management. Because we receive the bad handling of waste, but they will be exposed to diseases. So the Directorate of Public Health Services conducted some training of municipal, waste collectors, and so that they will know how to actually handle waste. So there are other activities that are training of healthcare workers on integrated management of neonatal child, illnesses, so that our own healthcare workers will be able to actually detect some early childhood illnesses, to be able to actually, do respond their need on time, and also incorporation of pediatric HIV treatment regimen into the IMCI module. And we train, a lot of people on case management of newborn and infant. So some of the achievements in terms of HIV, treatment is, there has been massive screening, but still now the people are not coming for screening. So, and the more people who screen, the better the country stands in response towards HIV. So the more people you screen, the better. But you need to identify the disease and then provide a response to it. But if people are not coming out, you realize that your response rate will have the virus circulating, and will not be able to actually respond to it well. So these are some of the some of the figures, and we have about 82%, which is a very high rate of people that are actually on treatment, meaning they are on act, that are consistently taking the HIV medication. So these are some of the figures that will also interest you members in terms of indoor residual spraying. In 2021, this is a campaign to also support malaria elimination. The Gambia, we are now at the pre-elimination stage as a country, so we have to push. The stage we are is even more difficult. You don't want to get back to where you are from. So we are pushing, and it has to couple with a lot of different action. Treatment is there, but you have to do spraying of the houses. You have to give under 5 kids also the anti-malaria. So these are some of the households with the targeted population as well that have benefited from the indoor residual spraying conducted last year. And these are also some of the seasonal malaria chemo prevention also in 2021 campaign coverage. Cycle 1, cycle 2, cycle 3, and cycle 4. These are the figures. But it proves to be a very good mechanism in the control of malaria, and the prevention of malaria. All of us know that even without saying that we have witnessed a decline of malaria compared to earlier years. So this also
just at one point. Yeah, so in that vein, we also realize that Gambia is a small country now, and then quite a lot of our communities are very close to the border. And then Senegal probably has communities close to the border. So we thought elimination may be very difficult for Gambia if we just work in tandem with Senegal. Because as we say, mosquitoes fly, they don't know the border. So they fly in and out of the EU. So we've been having what we call synchronization of aid distribution with Senegal. So we held one recently, last month, and it was at the border town. The previous 2 years it was at Ker-Aid. Yes, and this year it was at Takara. So usually the Senegalese malaria team and then the partners come, and our Gambia team also goes. We do it at ministerial level. It was very successful both times. Yeah, just to strengthen the malaria control program.
Yeah. Thank you very much, Honorable. I think these are, that was a big success, and globally they are learning the Gambia malaria response, their collaboration with Senegal. And also part of the response also is, as I said, our Pillar 10 is partnership. It's work with Institute Pasteur. It's a big laboratory institute in Dakar on syndromic surveillance through WAHO and Africa CDC, to see how we actually, also seek their support to test some of the samples that we have in relation to any outbreak, in the country. And to also, as part of the epidemiology and disease control strategies, is to implement a joint EDC, EDC's Epidemiology and Disease Control and Public Health Emergency Operations Center on malaria surveillance. Because we are now at the pre-elimination stage, we are now moving malaria to under the surveillance component, so that you'll be able to actually track the number of cases that are actually coming. So the ministry is now trying to put up surveillance mechanism for malaria. And also the Gambia has also been satisfied as trachoma free. We have eliminated trachoma, but we now need to migrate trachoma to the surveillance component, so that any single trachoma case, will have to be reported, and the country will have to put up emergency mechanism to handle that. And the ministry has also successfully conducted snail mapping in schistosomiasis endemic area, with a CRR and Upper River region, and applying molluscicide to these identified snail breeding sites. Because snail being a host for schistosomiasis. So under brief health product and technology, we have procurement of high quality.
Even though schistosomiasis is still prevalent in some of those communities, especially where children use ponds to swim in. So they get to the health facilities with bloody urine. In some communities, they take it to be trivial, and some communities they attribute it to puberty, that the young boys are becoming mature, and when they urinate, blood comes out. But after so many years, sometimes even decades, it tends to predispose to bladder cancer. It's one of the predisposing factors of bladder cancer. So the advocacy part, we also want your support, so that the communities, people refrain from swimming in those ponds. Thank you.
So part of the responsibility of the ministry is also on the supply chain management and the annual procurement of essential health medicine and PPEs, personal protective equipment, and other health products for 2021 has been conducted, and supplier commenced delivery of contracted supply and PPE and life-saving equipment also delivered. Procurement and installation of cooling systems to provide appropriate storage facility across the country has also been successfully conducted as well. And we also procurement of 2 15-ton and 4 10-ton distribution trucks commenced in 2021 to boost the ministry last mile assurance, meaning these 4 trucks will be at the regional level now to be able to do distribution within. Currently the status quo is ambulances will go and then pick supplies from the regional level, then go back. So now what we plan to do now is to have, when the facility needs it, then the trucks at the regional level will now take the commodities, health products to the facility level. So the 2 15-ton trucks will be at the CMS to take the materials to the regional level, and the 10-ton trucks, 4 of them will be stationed strategically to be able to provide these services for the health facilities. So we also have 7 containerized incinerators across the 7 health regions to be able to take care of our waste, including the 2 that we already have. That's the Ecostrial, the modern health, which will be launched very soon. We have the bigger one in Farato, and the smaller one is built here at Edward Francis Mall. If you are going behind the state guard gate, there's new construction happening. That's where the Ecostrial machine, the smaller one, will be. And also the migration from the paper-based system that we have now to a fully fledged logistic management information system, which is currently being launched, and the server is now procured, and now customization is ongoing. It's one of the issues that the minister has mentioned. So under the health communication and community engagement, we call it risk communication and community engagement. The Directorate of Health Promotion have conducted series of sensitization, community engagement, training of community health workers, training of village support group, and training of community members, for them to be aware of the risks around COVID-19 and other diseases of public health importance. because the community need to participate and the community need to take health into their own responsibility in order for us to be able to make impact in our intervention. And health promotion trained 850 community health workers and 2,540 community volunteers, which means youths and other adolescent groups, in how to prevent COVID-19, how to improve on their health, and how to pass the message also to their various peers as well. And we also have traditional communicators also trained on important health messages. And we also have religious leaders trained also and engaged on COVID-19 messages, because religious scholars are very important, in terms of COVID-19 and vaccination especially. So they are also being trained. We also have successfully have a synchronized broadcasting of radio programs, to showcase some of the good work that we are doing and to also influence behavior of the population positively towards their own health. And we also have a call center. That's the 1025, call center. These are some of the statistics, the total number of calls that are received in 2020, 2021, and currently 2022. People are still using the 1025, and we have people that are there that are receiving calls to direct calls. But there is work currently going on to upgrade that 1025, the 1025 call center to make it an emergency call center for the Ministry of Health. So these are also, we have also our social social platforms, the Facebook, the Twitter, and also our website. And people are definitely using it, and we also use it to also disseminate, message. That's why in any new, declaration by the ministry, we realize that people will rush to the Facebook, website and the Twitter to find out whether it is an authentic information or not, and they are all operational. So you can also get to subscribe to these areas that you can receive first-hand alerts of activities that are going on within the Ministry of Health. These are some of the capacity building programs for staff of MOH in relation to and other media houses related to risk communication and risk communication and community engagement, activities. Yeah. So that's the end. Thank you very much.
Yes, thank you very much. Yes, the PS also had the budget, so you have an idea of the financial aspects.
Thank you very much, Mr. Chair.
But before he starts on that, I think another big plus of the period is the launching of the community ambulances by the Ministry of Health. I think that's another game changer. The ministry, with your support, you are all part of it, in supporting and providing the funding, procured 80 community ambulances. These are high quality Toyota, these are Land Cruiser types that are actually located in the communities and are available to take the very sick, especially pregnant women, from their doorsteps to health facilities. I think this has been remarkable, and already we have seen it paying dividend in the sense that the delays that we used to experience in the conveyance of people to health facilities is reducing, and thereby people are able to get quick attention that is desired. We are fine-tuning the processes so that the efficiency is enhanced, but by and large they've already proved to be very useful. And it has increased our ambulance fleet as a ministry. Actually, within this period, what we got as ambulances is much more than what we had as a nation, when it comes to the ambulance fleet. Most of what we even had don't actually belong to the ministry. They are for the Riders for Health. So we are able to expand our ambulance fleet. I think that's how it is remarkable. We just thought we should mention that. Yeah. Thank you.
Yes, please.
Thank you very much, Honorable Minister. Thank you, Honorable Chair. We have a few slides to give you the scenario of the financial undertone that backs the presentation just done by Mr. Jibril. First, we'll start with the presentation outline, and we'll have the Ministry's budget program recurrent, and the budget execution on child and social protection family health program, and also it will show on COVID-19. We have the introduction, vision and mission board that has been mentioned already. We will not repeat that. And the structure of our ministry in terms of the budget, and I'm presenting only from the perspective of the national budget. First of all, on the one pillar of the budget is the strategy, policy and management, where we have a number of units and directorate that fall under that pillar for support. And they are administration and finance. We have project management, regional health management, health training and development, basic healthcare services, tertiary healthcare services, planning, monitoring and evaluation services, human resources, health infrastructure and logistics, health information system, and research quality assurance. Now, we also have the second pillar, which is the health promotion. Under one health promotion, you have a number of units, programmatic units and directorates, which are environmental health services, traditional medicine. You have health communication, school health and nutrition, water sanitation and hygiene, WASH, occupational health and safety. These are all budget sub-entities under the health promotion pillar. You also have the next pillar, which is the family health and child protection. Under the family health and child protection, you have programmatic units like reproductive and child health services, including IMNCI. IMNCI is the integrated management on neonatal child illnesses. You have the immunization services, that is the EPI. You have the primary healthcare services. You have the birth and death registry. You have the school health and nutrition national health insurance scheme. Now, we also have another pillar, which is the disease control area. You have also programmatic units under that, epidemiology and disease surveillance. You have the eye health services. You have the HIV and STI control services, leprosy and tuberculosis control services, malaria control services, non-communicable diseases, mental health, pharmaceutical services, diagnostic and laboratory radiology and blood transfusion. Now, in terms of the budget, from 2022, starting from 2020, because we are reporting on 2020 to date, under the first pillar, that is the strategy policy, the budget and the units under that, the total budget allocated for 2020 was 1,410,000,000 for $10. Now, they contain, you have, they are broken down as strategy policy 1.1 billion, health promotion you have 7.6 million, health, family health you have 139 million, you have disease control 135 million, then you have under another pillar the development. There are also development components, and I'm reporting both recurrent and report development. Now, the development component for each of those pillars, the total amounts to $82 million. Okay, in 2021, for the same programmatic units, the total budget allocated was 1.47 billion. And in terms of development, the total was 127 million out of that. Then you have budget execution on family health. Now, and the family health units are reproductive and child health services. We had an approved budget of 4.23 million in 2020, and for immunization services, 32 million. Primary healthcare, 791 million. School health program, 620 million, and birth and death registry, 1.6 million. National health insurance subsidy was 100 million in 2020. Now you have other budget lines that also contribute to this family health pillar. For example, in the area of HIV/AIDS, drug dressing and medical supplies and the diagnosis services. Now for HIV, you have the approved budget of 2.08 million in 2020, and for drug dressings, services, 1.5 million, and then for diagnosis services is 17.7 million. Now we come to the budget for 2021 for family health program, that is the reproductive health services. The approved budget was 1.4 million, and the immunization services, the allocation there actually remain at 32 million. As you would know, this is the counterpart funding that government provides to immunization services, because all the vaccines that are used are procured by partners, by Gavi, and because of that, government is expected to give counterpart funding, and for the year 2020 and 2021, the allocation remains the same. However, you know that at every time that a new vaccine is introduced and is to be administered, there is an equal amount of incremental counterpart funding that gets added to this. So this year, because of the introduction of other vaccines as well as these vaccines for COVID-19, we expect a higher counterpart contribution on top of this. So we will see as we go how much that will be. Now we also have for 2021 approved budget estimates of 1.2 million for primary health care, and 444,000 for school health and nutrition. For birth registry, we have 1.2 million from GLF, because World Bank is supporting, as Honorable Minister has reported, the digitalization of birth registry system, where we would have the ECIVS, the electronic registry system coming in. So the World Bank is supporting those preliminary aspects, and this is the government's contribution. Now, we also have spending on COVID-19, but I have a detailed breakdown that I will give later on after I finish the flights. So the COVID-19, it is reported here that the first case was registered on the 17th of March. And the first death was registered in the Gambia on the 23rd of March 2020, yes, 2020, yes. Now, the budget for COVID-19, it falls under the strategy, policy and management, and that is the pillar that is managed at the central level of the ministry. So the approved estimates was 775.5 million, and we have an allocation, an expenditure of, we have an allocation, as you all know, that was given by the government, but I'll give you the breakdown for that in another slide. The impact of COVID-19 on budget implementation. The pandemic has decimated jobs and placed livelihoods at risk. High number of healthcare workers contracted the virus. Healthcare facilities were closed. Funds allocated for annual operational plan activities were diverted away from other areas into COVID-19, and decline in key essential health service indicators that included OPD, immunization, skilled birth attendance. Now, the 2022 budget. On recurrent, we have an overall estimate in our GL in the national budget, both recurrent plus development. We have a total budget approved of 3.76 billion. But as at 31st of May, we have an execution rate of 22%, which is we have an execution rate of 22%. Now the recurrent component of that, the estimated approved budget is 2.06 billion, and out of the recurrent we have 33% execution rate. Development is estimated at 1.7 billion, and we have so far spent 9% of that. Now the key budget lines that constituted that constituted the overall budget. For example, the personal emoluments. What goes in terms of salaries and approved in the budget is 155 million, 155.3 million. Now, as of May, the expenditure amounted to 31.06 million. We have a balance in terms of personal emoluments of 124.3 million at the rate of 20%. So 20% of our budget is yet to be disbursed. Now, a component of that also is another component is electricity and sewage. We have an approved budget of 33.08 million, but we have a balance of 27 million and execution rate is 16%. Consultancy, this is where we pay for services like services of the keyboard doctors, for example, their stipends, their upkeep, their rent and everything. No, excluding their rent anyway, their stipend, principally their stipend. That's where we paid from, and the approved estimate is 100 million. But as of May, end of May, we disbursed 33.3 million, a balance of 66.2 million, and it is 33% execution. Training, we have an approved budget of 1.9 million, executed 82% of it at the rate of 738,000 dollars. Now, subvention is where 1.19. Yes, it's 1.19. Yes, it's 1.19, not 1.9. It's 1.19. That is the training approved training allocation. So subvention is where we pay for services of our contracted partners, like the Riders for Health. We give them a monthly allocation for managing the entire fleet of the Ministry of Health, including and primarily the ambulance services, and we have an allocation. And then also under this board is where we pay or we transfer monies to the hospitals, all the 7 tertiary hospitals, to pay the salaries of their staff. They are a sovereign institution under the Ministry of Health. So the overall allocation, approved allocation for that entire budget line is 114 million. As at May, the execution rate is 43 million. 43 million has been executed, leaving a balance of 71 million at the percentage rate of 38% on the execution.
Yes, can we repeat that figure again? Sorry.
Now, the approved budget for the subvention line, and this subvention, okay, the breakdown is both salary and the operating cost for the hospitals, for the 7 hospitals, as well as our contract allocation for riders for health.
Riders cannot be. Because if you look at the figure of riders alone, it will take more surplus, isn't it?
Yes.
Huh?
Yes.
So this probably is just the
No,
health facilities.
yes, this is just the health facility. Yes, exactly. This is just the health. In fact, riders fall under a different, a different subvention. You know, you have several subventions. Yes, this one is for the hospitals only. Yes, I beg your pardon for that. This one is for the hospitals alone. Yes, riders is not reported here. Okay. So we have another key budget line, or a key sub-budget line, which is the drug testings. This year we have an approved budget of 269.91 million. This is the allocation meant to facilitate the annual procurement of national medicines, national medication. And so, as at the end of May, we have an execution of 70.16 million, which is 26%. And the process of procuring the national medicine, national drug requirement for 2022 is ongoing, and as Honorable Minister has reported, right now we are receiving the drug supplies procured under the previous year, which are now being supplied, and so being consumed at the moment. The National Pharmaceutical Service Director will give us an update on that. We have another budget line, or a sub-budget line, specialized and technical materials. This is mainly for the procurement of laboratory medical equipment, including laboratory. We have a 30 million approved budget for that 2022, and its execution as at end of May is 2.9 million, and it is 10% execution rate. However, the contract for the supply of laboratory equipment have been awarded, and the deliveries are expected. Okay, so I have a question. So the other one is vaccines. Okay, so the vaccine allocation, just like I reported on the 2020 and 2021 for the counterpart funding against the immunization services, is this year budgeted at 35.2 million. With the increase in, with the introduction of new vaccines, we are expected to pay a higher counterpart contribution. Laboratory, the process of disposing that now is on, because as of last Friday, I was engaging Minister of Finance, and they told me they have factored this for the next allocation, so that they can dispose this, and it's a one-off payment that we do. Once we do that, it is 100% execution. Laboratory equipment and instruments. You have 200 million budgeted for the procurement of laboratory equipment and instruments under 2022. Hospitals, clinics, and health facilities. This is the regional the regional health services. This is- We have 221 million approved budget, and as we speak, about 128 million has been disbursed, because you know that we are also under our development paying for the construction for the construction of a number of new health facilities, which are paid against this particular budget line. So we have as we speak significantly executed most of those projects are now at the finishing end, and so the payments were also almost coming to an end. We have 58% disbursement. We are just waiting for the finalization of those contracts, and the next batch of payments will be executed. So, honorable ministers, we have honorable members. We have also the financial disbursements as far as COVID-19 is concerned. You will all know that you recall that the government in March 2020 allocated 500 million to the Ministry of Health, and later on there was an additional 250 million allocated. Now that amounted to 750 million in 2020-2021. So as of December 31st, 2020, the total funds received the total funds used from the 750 million was 741 million and 0.45. That is an execution rate of 98.81%. This, of course, expenditure went towards hotel accommodations, the quarantine facilities, the procurement of goods, the procurement of fuel, and payment of allowances to the frontline workers, and interest to the security and other payments that have been made in the form of transfers. Now, with regards to hotel accommodation, in 2020-2021, a total of 188 million point 58, about 25.1% of the total COVID funds allocated. 93.5 million, about 12.47% went into the procurement of goods. 5.7 million, 0.77% went in the form of fuel. 110.69 million went into the payment of allowances to frontline workers, that is 14.76%. To the security, it was 12.51 million, about 1.67%. And there was a direct transfer that was made to the PCU in lieu of the project activities that were supposed to be carried out with support of the World Bank, but government had to transfer funds to implement those activities, while World Bank contribute towards while World Bank procure the COVID-19 ambulances. So that amounted to 100 million and is about 14.4%. Now, basically those are the breakdowns for okay, so out of the COVID-19 funds, we at the end of 2021, there were no new replenishments of the COVID-19 fund. However, recently in 2021, the COVID-19 account has been replenished, even though disbursements under that has not been made yet. We are waiting for certain decisions to be able to start disposing on those. So, honorable members, this is what we have in terms of budget execution. I'm sorry that my apologies that the slide could not be captured there, because the version I have here, I'm finding it difficult to download it. I don't know what for version it is, or maybe my computer didn't have an updated PowerPoint, basically. So thank you very much.
Thank you.
Thank you.
I just thought, if I may, Chair, that the figure you mentioned, Honorable was asking about, that looks more like that of riders. And then the second figure was that of the hospitals.
I think so. It is like
Yes,
it
so
is
riders,
riders is
currently pay
114 million.
9.5 every month.
Yes.
You multiply that by 12,
Yes.
will be 114.
Yes.
So that's for riders.
That's
the
for
first
riders.
one.
Yes, 114.
So the rest,
yes.
the 250
The
further down,
Further down.
looks
is-
like that is for the old
That is for the
hospitals.
whole-
That's the subvented institutions,
Yes.
including Edward Francis
Yes.
and all the other
Yes.
hospitals that are
Yes.
subvented.
Yes, yes, exactly.
Yeah, and the councils.
Yes.
Yeah, and then
Yes.
the medicines control
Yes,
agency.
this is
All the
the-
subvented
yes,
institutions
221
that
million.
are
yes.
under the ministry.
Yeah,
yeah.
221 million. Yes. Thank you.
Thank you very much.
Thank you for that card.
I think you are done.
Yes.
Yes, Honorable, just a last thing, I said let me before, so that we put everything at once. Thank you very much. I think the additional one is the issue of drug procurement. I think that's a special issue that needs to be discussed, because we think we need to be able to modify the system. Currently, the Director of Pharmaceutical Services is here. How drugs are procured in the country, there is what we call an international competitive bidding, which we believe is a good system. The challenge we have is the timeliness of the system. So each year there is what we call drug quantification. The Director of Pharmaceutical Services sits with his team, and they invite all the stakeholders to meetings to quantify the national drug requirements based on a number of factors, based on the service data, based on the historical information and historical consumption, and based on the projections. They come up with quantities that need to be procured. These are costed using standard costing mechanisms, just to have an idea of the estimated cost, because the actual cost can only come after the tenders. Now, this is put forward, and then they start the process. Now, the tender process itself, tender documents are developed. When they are developed, they sent to GPPA, come back. When there's approval, they are advertised. When they are advertised for 6 weeks, bidders participate. When they participate, they submit their documents. There is an evaluation. When there is an evaluation, after the evaluation, now the winner is selected. When the winner is selected, they wait for a standstill period and then notify the winner. They come back, contract negotiation, and then when contracts are negotiated, they now start counting the supply date, and then the transfer to the individual. Transfer funds from the government to the individual, and then like the current one we having the challenges with. The supply period is 4 months. So you can see all these months have passed doing other things. And the supplier said the minimum he can supply is 4 months, 120 days. When I was told, I was furious. I said, no, we cannot, but that was it. They couldn't make it shorter, because they said that was the time that they are going to place the orders, because drugs are not manufactured and stay on the shelves for who can come and buy. They will start manufacturing them when the orders are placed. So now with the shipping challenges of COVID-19, that shipments that should take 3 months end up taking 6 months. So this is the dilemma now we have. So it is a big problem, and then we need to look at it holistically. But I think that also brings us to the new modality that we want to propose, as it is happening in other countries, which is making the central medical stores autonomous or semi-autonomous, or autonomous, in the sense that this is the model that Rwanda has and some other countries. They are able to plan, and it has to have a legislative framework. And we want to put the concept together and bring it to you, and then the legislative part, we want to look at the provisions that are there now, establishing that entity, and if it needs some modifications, and that's how we come to you, we'll bring it to you after having the interaction, but we just want to introduce it now. They operate as an entity with different provisions. They also are an entity, a government entity that is that will undergo audit processes. They follow the rules. They have guidelines that are put together by the assembly and government. So they operate that way. Now, what happens is they now supply each of the health facilities drugs, and then the health facilities pay them, and they plan their procurement and so on and so forth. The procurement of drugs is very cumbersome, and that responsibility, if it can be away from our ministry and be given to a different entity, I'll be very happy, because hopefully that entity can manage it better, because that will be their main function: procure, supply, and manage their procurement. But that is giving the ministry a whole lot of work, when I believe we should be focusing on provision of care. And then we get drugs, provide the clinical services that our people need. So I think I look forward to that, and I think it's a very good entity. The Rwandan model is beautiful, and this becomes even more relevant with the National Health Insurance Scheme. I'll give you the references as an example. With the National Health Insurance Scheme, the facilities will be recruited under the authority. Now, they will provide services, and each of those services there is a cost attached, and they will also provide drugs to the patients, and then they will now bill the insurance authority. Now, how can they bill for things that we, for example, have supplied to them now, the current arrangement? We supply to the hospitals free of charge. How are they going to bill? The insurance authority. But if hospitals were now procuring from this autonomous body, then they can now write the bills to the insurance authority. It pays the hospitals, and they procure from the autonomous body, so that the ministry is not in the procurement of these drugs. I think it will be a very good thing for this country. Yeah, that's my proposal, but we say we prepare your mind, and then that entity, the autonomous body, is accountable to the assembly, is accountable to the parent ministry, and it will be audited on its own merits, and so on and so forth. We believe that will enhance performance and the provision, continuous flow of drugs and medication. The second one is there is a public health emergency operations center we have, but with the outbreak of COVID-19, we think we need to institutionalize this. We need to strengthen it legislation-wise. So we're looking around at models that prevail in other countries. So that is one area that we hope to bring to your attention, so that we work together to actualize that, so that to strengthen that public health emergency center. That will enhance our emergency preparedness, and it will make them being responsive and ready to operate without many bottlenecks. That's what some other countries have. They, as soon as the stimulus is there, they swing into action without much bureaucracy. Now, as we go along, we also have quite a lot of acts that we think need to be modified, to be amended to fit the current times. So those are also things we are looking at. We are actually looking very much forward to your commencement of work, so that we can look at those acts, that need relevant amendments. So we intend to take a lot of your time, so that we strengthen the health sector when it comes to all those acts, and then the policies and then the acts that give us the mandate to do certain things. We'll take a break for now, and thank you very much for your kind attention. Yeah.
Thank you very much, Honorable Minister, and thank you very much to all the presenters, and thank you very much, team. Now let's flesh up, and because now it's turn of the honorable members. They have been sitting patiently listening and following all the presentations. Now I open the floor. If any honorable member have any question, comment. No, I think it was a consolidated thing. So that was
So it was summarized together.
Yeah.
They gave to Jibril to put
yeah,
together.
that's what the director of planning presented. So now I will open the floor for discussion with regards to the presentations that were made here. If any honorable member have any question, comment, or contribution on the subject matter, please you are free to ask anything, because these are the right people who can answer the questions. So Honorable Biden, happy.
Thank you, Honorable Chair. Good afternoon, Honorable Minister and team, PS and the directors all present here. Good afternoon to my colleagues. I'm grateful to be part of this committee. This is my first time being an elected member, and then I'm opportune to be part of this committee, which is going to play an oversight function on one of the most important sectors of this country, which is health. And then being informed through this briefing about some of the steps and interventions we've done, it fills my heart with some hope that we are going somewhere with regards to attaining quality health. You've mentioned many of the innovations that you've carried on regarding the electronic medical recording systems, the electronic birth certificate, and then even major steps in trying to establish a kidney transplant, open heart surgery, and all those things. I think it's high time Gambia moves forward in trying to, because you as in ministry, you know the number of people who leave this country to go and have some of these services. Gambia, a lot of people leave this country to go even to our neighboring country, Senegal, and then they have a lot of economy in terms of Gambians investing in the healthcare, and then it's good that some of those services that are not here, the ministry is making efforts to have them here, and then also I listened to his presentation concerning the services across the country, the expansion of healthcare services. What I was expecting to hear is regards to the decentralization of major medical services. Like, you know, we have a lot of medical, you have Farafenni Health Center, you have Farafenni Hospital, Buyam Hospital, Bansang Hospital, and this we call them hospitals, but do they all necessarily have all what it takes to be a hospital in order to reduce the number of referrals that are coming to Banjul? And then you've mentioned Brikama Health Center, having another location in Brikama Center. I think the ministry should be looking at how to have a hospital in Brikama as well, so that they also minimize some of the cluster areas that need services from central. So I think I want to understand what are the impacts that you are doing towards Bansang Hospital in terms of those major services, Farafenni Hospital, Buyam Hospital, and even Basse should have a hospital. So we want to hear some of those things. You've also mentioned the attitudes of staff. The minister mentioned it, and this has been honest comment that you have issues of attitude, and this everyone attitudinal change with regards to coming on to work on time, and then the things they are supposed to do at the hospitals. And this every Gambian that frequents our hospitals notice these things, and if anyone who takes patients to hospitals notice these things. And I think ministries should take. And then sometimes the most surprising thing is that most of our medical personnel who are in the government services provide services at private clinics. And then if you go to private clinics, you experience a very quality service. And then, but these are the same people who are working in public sectors. So it means their attitude towards work at government services is totally different from what they portray when they are working for private sectors. And then this is something the ministry should look into and see how we police the behaviors of people who are giving medical care. Because I myself am a victim of some of these things, and I observe it like it's been very honest. And then I want to draw also this general thing. This other thing is like a comment regarding, let me be constituency bias here. Like I come from Talindi, I'm the NAM for Talindi. And then my predecessor, Honorable Fatimata Jawara, has made steps because Talindi is the only community in KM that does not have a community health center. And we were fortunate to inherit a community center through a project that the German people left us. And we've been trying efforts to make sure the ministry put a hand in that distance by providing the staff and then some of the necessary things so that we have, because Talindi is densely populated, and then we are very unlucky in terms with regards to Fajikunda, Bundung, Latrekunda, and other areas that have been enjoying these services. And then we don't know why was it difficult for the ministry to at least, provide us. The infrastructure is there, the building is there. All we need is the staff to come and deliver services, and then you'll be doing a great service to the community of Talindi. If I know this is just an opportunity I'm seeking. I'll be knocking on your doors, but we in Talindi field somehow deprived of some of these basic access to health services with regards to your goal, accessibility. So you've reached far widest areas of the region, but you've not reached us as far as your services are concerned, and this is something I want to put to your office. Yes, the other issue is you inform this committee. We also know about this sniper thing that people use on Smoke Feast, and then from social media, I understand your ministry constituted a committee to investigate these things. Is that?
I think that one.
No, it's an OLB.
Yeah, I mean, you can talk about it.
It's a question, not necessarily.
But for that one, we haven't engaged
It has been dealt with.
last week. Probably we had to.
No, I know the engagement. I know the ministry took steps. I mean to brief us the findings.
Okay.
That's what I'm saying. Not.
Okay.
I know.
Okay.
I was not in the meeting, but I heard this thing. I mean to update us.
Okay.
The steps they have taken, how far. That's what I'm saying.
Okay.
I know they have constituted a committee to update us. Yes. So my last thing with the electronic birth certificate. This is a monumental step. I think we have to commend you very much for some of the wonderful initiatives the ministry is coming for, especially this electronic birth certificate. But I want to know whether is it going to be a new one, only newborns, or you're going to go back to some of us who have had this thing, to have all these things in the yes. It's important because it's all part of data or something. So if you're not thinking in that way, I don't know, maybe that's one is a major one. You are starting with the new ones or something. But then I think I welcome these things. I think I welcome these things. The other thing is about budget implementation. In terms of development, you've mentioned that 1.7 million is for the development budget, and with this, only 9% rate of implementation. I don't know if I get it right, but it seems way below the mark. If we are almost mid-year, and then you are 9% into the implementation of your development budget, which is 1.7 million, and then your overall budget is 3.76 billion, and then 22%, and mid-year. So these are some of
Maybe they have no money.
So I've talked too long.
Thank you very much, Honorable. I don't know what approach are you going to take. Are you okay to address issues as they come, or you want to?
Okay, since this one is long, maybe I can take
Okay.
it. Thank you very much, Honorable Baji, for those questions. So the decentralization is something that we are strengthening very, very much. So the plan, actually, the policy now. So the regional hospitals, those hospitals. So we want the hospitals now in the regions. We want each region to have a regional hospital. So Basse District Hospital now will be Upper River Regional Hospital, with all the accommodations, all whatever it takes. North Bank Regional Hospital. But for example, North Bank is very large. So we want North Bank East Regional Hospital, North Bank West Regional Hospital, like that. Western Regional Hospital. So it is not just the name. So what we want now, which we have started already, each of these hospitals will have very strong presence in the 4 major disciplines. That is internal medicine, surgery, pediatrics, and obstetrics and gynecology. These are the major disciplines, and others come around them. But most people, these are the categories they fall in. Thereafter, other specialties, they can be referred, some can be referred to the Greater Banjul area. But if they handle these areas very well, most of the patients in their regions would have been seen. So this is what is going to happen, inshallah. And we've already started recruiting those doctors from Cuba to come and fill in those gaps. So each of these hospitals is going to have a fully functional theater to do surgical operations and obstetrics and gynecological operations. So that is the plan for the regional hospitals. Brikama is actually a hospital that's going to be built. We were contemplating a 100-bed hospital, but now we're increasing it to 200-bed hospital. We discussed it with the World Bank. So it's going to be a big hospital. That is also going to feed into the Farado Hospital. And so you've all had the pronouncement of the president. Inshallah, we're going to build a teaching hospital in Farado. So that process has started. So this first phase, which is the emergency treatment center, which is 104 beds, is the first phase. We are coming to build another structure there. We in discussions with the Chinese embassy, and they put forward a proposal whereby they are coming to now build mother and child unit of that place, maternal and child hospital component of that place. So we are going to build like that. Emergency treatment center is there, the waste management center is there, the mother and child hospital is there, and we discussed with the First Lady's Foundation, who have been working very hard with some partners who want to help us build a cancer treatment center. So in fact, they want to come for foundation laying ceremony very soon. So all those we want to house in Farato over there. So at the end of the day, it will all be linked to form the 1,500 bed teaching hospital. So the decentralization is going on rapidly. And what we also plan to do is to have monthly outreaches where doctors, nurses, public health officials, pharmacists, laboratory technicians, and everybody will go as a team into a region on a monthly basis, including myself, to go and look at where the disease burden is high. We do a few days there, do a camp to strengthen, to increase the strength of our local staff, health workers who are there. So this is also very high on our agenda. That's the monthly thing. You mentioned the issue of the attitudes. So the attitudes is a big problem. So when you were talking about you meet the same people in various places, I have been referring to that as it's unfortunate that some people have a morning attitude when they are in government facilities and an evening attitude when they are in the private facilities. Somebody who will scream at patients and their escorts in government facility. In the evening, you meet the same person at a private facility, and he's so nice to you, welcoming you, asking you to sit well. So it's not acceptable. People are people, humans are humans, and government work should be taken very seriously, and the people deserve respect in our facilities. So we're going to monitor this, and in that vein, we're instituting a committee called Health Facility Monitoring Committee, whereby we have some government workers, health workers, and then some are going to be from the community to give it a balance. And these people are going to go around unannounced into the facilities and tell us in reality what is happening at the facilities, so that we monitor that. But with the performance management system, I think it will address the issue of attitudes, because all those will be checked for people who behave well and against people who do not behave well. So the issue of the community health center in Talindi, yes, your predecessor brought the issue forward, and we'd actually been working hard on it. She invited me there, so I visited the place with my team. So we've seen the place, and just as you said, it's a good thing to take it up. I think the typical thing was, I think there were some challenges with regards to running the place, from what I learned. The community, the people who built it, and how they are operating it So I think government is ready. When those are sorted out, you kindly let us know with partnership between the community and the donors. If it is sorted out and then you want this scheme, we can come in. But actually, the other thing we put forward, which is still on the table. So Mr. Jadi Jibril did mention that we plan to build more health posts. So there is actually one for Talindi. There is a health post we are going to build in Talindi. The challenge was we tasked them to look for land, which was difficult also. So we'll bring that to you too. Still, if you have somewhere that can accommodate a health post in Talindi, that is also accessible to the people. We are ready because in fact they are working on it now, and there is funding for that from our partners. Gavi is supporting that project, and we now finalizing it so that the construction work can start. So now if you have land, you let us.
Not cut me, but I think Honorable, you can engage him further on that.
Yes,
Exactly. Yes. The issue of sniper as something that was added, an agent that was being added to food stuff. If it is true, it's disheartening and it's unacceptable. But one thing I also wanted to bring attention to, food, the care of food has not been the mandate of Ministry of Health. That is where the people assume, most people assume that it's our mandate. No, it's the mandate of the Food Quality Assurance Authority. It used to be under the Ministry of Health. There was a unit in the Ministry of Health that was responsible. But now a new entity, authority, has been formed, and they are under the office of the Vice President. So when this happened, what we did, when I heard about it, I alerted our team, the entire team. We gave the leadership of that to the Director of Public Health, because anything that potentially has, poses a risk to the public health, to the health of the public, we certainly are interested, and we want to get to the root of it. So our Director of Public Health dispatched his team. They interacted with the Food Safety Authority, and then we learned that various investigative mechanisms were started, but we haven't found have not been updated on the outcome yet of the finalization. But I was told that samples were taken to be sent elsewhere to confirm to confirm the veracity of that situation. Yeah, so that was it, and I think the committee also called them, and they all had a good meeting here, and that's been followed up. The electronic birth certificate. So the idea is to have everybody get the new type. So we'll all get the new type, which is very good. And as part of your tour, we'll be very grateful if you could visit the new birth certificate unit, birth registry. It's recently renovated and is very nice. It's in Banjul. If you can just pass by to see the gadgets and then the structures, what they have. The World Bank supported in that, and I think it is very good. Yeah. The budget implementation, well, PS could talk more about that. But I think sometimes the challenge also is general terms. Is that sometimes our people send requests that they follow up and it doesn't come. So in fact, you have already so many requests at the Ministry of Health for allocation, Ministry of Finance. So when the allocation doesn't come, then you cannot implement. Okay. So just as the chair said, maybe sometimes there are issues. Maybe the funds are not available at that time. Of course, as people keep on saying, budget is an estimate. It doesn't mean the monies are lying down. But I think we've been having quite some challenges. They've been supportive, but sometimes the certain allocations do take time, and people keep on following them up. Yeah, I don't know if you want to say something.
Yes, exactly, Honorable. That's exactly what I was going to say. Just to add that, we have been having that challenge really. And for contract execution, development, you spend it on capital expenditure, like you are buying heavy equipment or you are paying for construction. And those are also based on contracts that you sign, and you follow implementation timelines that also inform your process of pay. So if your contracts don't mature based on work certification, you cannot disburse even if you have the fund. So that might be one aspect of it. But the other aspect is what the Honorable Minister has said, and that has been a challenge. With Minister of Finance, they've been very supportive over the period. However, their support was mainly, in the area of COVID in terms of release of funds. The normal DLF has been a challenge for us to get allocations released under the normal DLF as far as development is concerned, because their eye has been that, well, you have COVID funds, you have COVID funds, use those ones, but those ones are specific for COVID-related activities. So with the other facilities that we are doing, that are outside of the COVID arrangement, this is where we pay them from. And if we don't get the allocations under this budget line, it's difficult to spend. So far, this is what they have been able to get, and this is what we are. But as far as our contracts are ongoing, we're hopeful that before the end of the year, when coffers, become released, we will be able to get, and once we pay for the contracts, we'll be able to exhaust the balance. Thank you.
Thank you very much, Honorable Minister, and thank you very much, Honorable Baji. I think on the issue of the budget, just highlight everything in the report you're going to give us, the challenges, then during the budget, bilateral with the ministry, these are issues that we can take up, and inshallah, we're going to take it up and support you on that. The Honorable Member for opinion.
Yes, I think, thank you so much, Honorable Chair, for giving me the opportunity, and to the Honorable Minister and the team. Let me also seize this opportunity to thank you vividly for those meticulous presentation, explicit and meticulous presentation. I think I have to thank you for judiciously utilizing the funds that have been given to you during the time of COVID-19. Though it's mega resource, at least you and your team did your best to do what is needful for the Gambian people. We have to commend you for that. Yeah, well, one thing peculiar I don't hear from the presentation is the issue of traditional medicine. We get prevalence in the country. Many people are involved in this traditional medicine administration at the same time also curing with the advance. So, is there any legislation around to regulate them, or is there any need for the ministry to come up with a policy of managing them? Because the way things are going, sometimes you don't even understand. And what you normally found in their places, the environment, is not that much conducive and it's unhealthy. So people can pick up anything from there. So I think there's a need for the ministry to pay attention in this area. Yeah, that's a peculiar question I really wanted to ask. But the rest of the issues were being extensively touched by Honorable Baji. I think normally, those who speak before you, when you come with, you have very little thing to say. But obviously, I'm really impressed with the success you have registered, and the new innovative measures you are coming out with to strengthen the ministry. That's really, really, really interesting, and we will encourage you and your team to keep it up, and continue the good work. And in this particular area, I also want to be biased. That's typically about my own area, my constituency. With renovations and the new facilities you are building, I've seen it. I've seen the villages. I've seen the constituencies on the slides. But like my three most strategic health facilities in Obanyon, that's Nema Kunko, Albeda, Chechon. These three places, my minister and team, I think I know you have been supportive. We have to be grateful somehow. But we need the facilities first to be changed completely. Thank you for giving us a new ambulance to that of Nemukungu facility. But the ambulances at Chechona and Albeda also are somehow definitely, they are not that much in good condition, so they need to be somehow replaced. So think I have to put that tax on PS. Yes, to write to the Lions for Health to replace them because that's where they came from. Yeah. So thank you so much.
Have you landed now? Have you landed? Yeah. Thank you very much. And in fact, you know very well how we operate. So the ministry, they are always our partners. I know you can be knocking on their doors and whatever. So, Prime Minister, just please respond on the issue of the traditional medicine.
Yes, thank you very much. The ministry has a traditional medicines unit that is staffed. They've been doing most of the coordination of traditional medicine in the country. I must, however, say it is a challenge because traditional medicine is not typically standardized. So it is challenging for any country to really have standards for all the practitioners. Because you typically don't even know what some of them even do. They tell you these are the herbs, but not just herbs, they provide incantations that do the treatment, which some will not even open up to. But WAHO, West African Health Organization, has been working very hard. I think recently they put up a pharmacopoeia, Mr. Sabali, yes, on traditional medicine. Actually going into the communities, country by country, and putting together all or most of what is used, so people know, because that's a starting point. And then they have, in some countries, they even teach it in the universities now to standardize it. So that is very helpful. So our units are working very hard. I would allow Mr. Sabali also to make a few comments on that. But I think one challenge we have is some of these issues that are mentioned in the radio. When they advertise like that, regulating that, the Directorate of Health Services is actually looking at that, what is allowed and what is not allowed. And these are also areas that if we see there are regulatory gaps, we'll come back to you to support us in that, so that we are able to handle it properly.
With legislation.
Exactly, the legislation, and then so we're looking at that. But the Directorate of Health Services is doing that. And there was a time the Medicines Control Agency, I was told, even wrote to them to stop these things they do on TV, on radio, particularly saying they could do A, B, and C, attracting people. But at the end of the day, we get complaints that that is not what happens behind the scenes. Yeah. Thank you, Mr. Sawan. You have a comment?
Yes, briefly.
Thank you, Honorable. Thank you, the Chair of the committee and honorable members here, and then the directors and all the colleagues here. I think the Honorable Minister said it very well. We're having some challenges regulating the traditional medicine in this country. At the moment, the unit is working towards having a policy. I think they are working very hard to have a traditional medicine policy. From there, the other legislative arms instrument will be coming up. What we are doing at the moment in the ministry is to use the medicine control agencies, that's Medicines and Related Product Act, to control the products. So the advertisement on products, there is a halt on that. The medicine control agencies have wrote all to practitioners to desist from promoting their products. But when it comes to practice itself, that's why we are having problems, because we have been difficult in terms of regulating that, because there is no instrument for now that regulate the practices of traditional medicine. So that's the weakness in the system. As the Honourable Minister said, that he will come back to you to come up with an act to address those anomalies in the system. I think WAHO has really helped in recent years to regulate the practice. Some countries, as Honourable Minister said, are now integrating the traditional medicine, the conventional medicine, in a way of having herbal traditionals trained at the university up to the very high level, and they are now sitting in the hospitals, and then patient will make a choice of either seeing a traditional practitioner or conventional one. So we are working towards that direction. But for now, the most fundamental thing is to come up with a policy. From there, we come with other legal instruments. Thank you.
Thank you very much.
Thank you. So the ambulances in Albreda and Kercherno. So we actually now looking at the fleet. Those are the riders' fleet that we have, and then our fleet that are old. Some of the vehicles riders manages belong to government. They are quite old now, and we're looking at them as we get. We hope to still get some more community ambulances, where we realize that the 80 is not enough now, and also replace some of the old ambulances that are in the communities. So this will be included in that. With the renovation, so we embarking on upgrading and renovation of all health facilities in this country. We started and it's going on well. Of course, funding is not readily available, so we've started engaging partners. We engaged Global Fund about a year and a half ago, and we are following it up because there is an indication that they'll be interested in supporting us renovate. The other option we say on standby is to engage with Social Security. The former MD did give indication of possible support so that they support the ministry renovate all the health facilities in this country and provide accommodation for our staff all over the country, and then the ministry could pay, annually we could pay some amount for a number of years. So these are innovative things that we thought Social Security could help us do, and we are going to engage them and the Ministry of Finance to look at the framework to see if we are able to do that, going by the laws that exist, if that is something that is possible, is an alternative. And it's going to be done from place to place. But that of, especially that of Nemakunku is high on the agenda. We had done, I've seen and we need a new labor ward over there, an expansion at that space. When you enter the first space you reach before the buildings. Yeah, at Kercherno, after the windstorm, experienced some damages. The roof of some of the where the staff stay. So we're also looking at that. That one will be done soon, and then some, at least some minor renovations will happen before the rest of them. So this is the information on that. Thank you.
Thank you very much. Thank you very much. Why are you clapping? Thank you very much, Honorable Baro.
Thank you very much, Honorable Minister and the team. We are very impressed with what we had and some of the plans that you have. But in the specialist area that I'm concerned, looking in the provinces, if you go to Bansan Hospital or Basse, you have limited specialists that are addressing the need of the people, that have increased the number of referrals. And you did not talk much about those areas. And we were also briefed with a data recording system called My Child. I don't know whether you also interact with them, because they show us beautiful stories that we believe that the ministry could look at and adopt even in the supply system. And I'm also very happy you talk of the procurement. I think sometime 2019 drugs will be received in 2022. It's very disheartening. What is the problem and how can this be averted? Because these are a big challenge. The issue of medicine everywhere is said, and then they will always tell you procurement. And Ndemban, currently we visited Ndemban. What is happening there is very sad. A patient would have an accident, will be referred for 1 week without an attention of a medical doctor. I don't know whether you people observe. That is the Korean situation I'm talking about. It's really tough, doctor. People are coming from this upland 1 week without a medical doctor's attention. And that's very sad. And this, I haven't heard about some of the responses that you are doing now. And the other issue is from the area that I come from. We had poor road network, and some other areas are completely disadvantaged. Is it possible to help them? Because looking at an area called Jeddah, there is a water network that still now women are delivering on horse cart at my area. And coming to the community ambulance, there are challenges that they have, because those community ambulance, the format that was taken, because I challenged at the local authority, that is the local council, for them to intervene in terms of fuel. But now what we are getting is that the ambulance services, we are benefiting from the COVID fuel, and then the COVID fuel is limited. So still now the community are asked to buy fuel. So when I engage the area council, all they said that the Ministry of Health did not involve them in the process. For the fact that the Ministry of Health did not involve them in the process, they did not know where to pick up. So this is issue that is happening, and I just want you to look at that area. How do you incorporate with the local one? Because even the drivers are not getting their salaries since the allocation of the ambulance to that area. So thank you. That is the something. Yes.
You still have more. You can still.
No, I don't know.
Thank you very much. I can go.
Yeah, you can.
Yeah, thank you very much. Starting with the issue of specialists, typically training specialists is a big challenge, and it takes time. So for all developing countries, even developed countries have challenges with specialists. But now, quite a number of the specialists we have in the health sector are from Cuba, the majority. But we said as a country, this cannot be forever. There has to be a sustainability plan. And I'm happy to inform you that we have started that. Now we are training specialists at Edward Francis Small Teaching Hospital, medical specialists. Now the young doctors who graduate here, most of them are very enthusiastic because they have now a career pathway. So here now we are training surgeons, we are training gynecologists, we are training family physicians, general physicians, and we are training obstetricians and gynecologists as well. So it is happening right here. That is why we brought in, with the support of World Bank, 15 professors from the sub-region who are here training them now. So that is happening. So, and some have recently passed their exams at the middle level, so they have gotten their membership. So it is left for them to go for another 2.5 to 3 years to get their fellowships and become like specialists like myself and some others. So this is happening. But before then, patients continue to get sick and they need specialist care. So that's why we are bringing in more people from Cuba. That process has started because some of them, they are doing their air tickets. Very soon you'll see specialists in those facilities, more specially. The My Child thing, I had gotten quite a lot of briefings about them and the benefits. Of course, in the past, we realized that they were having challenges. Maybe they have issues that some units in the ministry were not very pleased with. But I think those have been addressed. And recently, I met a team that is advocating that, and we want to continue the collaboration that we have with them. So I think that is going to be a win-win for the system and for that project, right?
Yeah, Honorable Minister, before you pass that one,
Yes.
My Child program, because they came here, we had an intervention, we have an engagement with them. But like, it's a program.
Yes.
So is your ministry ready to integrate it into your routine program once the project phased out?
Yes, so yes, good. Yes.
Thank you very much, Honorable Minister. My Child has been integrated in the Ministry of Health since 2016. It was a pilot phase initially for Western 1 and 2 from 2016 to 2019. So as I speak now, the program is across the country, and every child born in the Gambia is recorded under the My Child solution. So as per the engagement with us, we had a transitional phase from the project mode to now the transfer and integration into the MOH system. As we speak now, a server has been created by my team. In fact, as part of the implementation, we had a capacity building plan as part of the MOU that we signed with them in 2016 for implementation. So we are gradually, close to 85% implementation of the MOU agreement, because it's the Ministry of Health that house the My Child project. The scanning stations are within the Ministry of Health, meaning at the RADs. So, and the internet that is used for the scanning is the Ministry of Health that pays it. So, but gradually now the IT team has now migrated the server to a new Gambian server, so that our information will be managed by us. We have now integrated My Child with the DHIS2. So any information that is on the My Child is automatically pushed to the DHIS2. But the DHIS2 is a national database. So any system that we are bringing up should be able to interoperable with DHIS2. So we have advanced on the implementation. The issue now we are talking about is now sustainability in terms of when the project actually ends. But that's why we have integrated it to the DHIS2, so that all the information will also go into the DHIS2. In the event that we cannot actually sustain it, we are building up an e-tracker, immunization e-tracker, on the DHIS2. But My Child is also advancing in terms of individual data, so that the information now, individual level, which is currently at My Child, will be pushed directly to the DHIS2 without any alteration. And a team of IT officers may, are already settled for an intense 2 weeks capacity building on My Child server management, and also production of new models of My Child, and also advancing the interoperability with DHIS2. Yeah.
That's good. That's very good. I think that's okay. That's okay. And you can on support on that, please.
Thank you very much. Thank you. Yeah. Now the second issue of the third, the procurement of drugs, just as I mentioned. Actually, yes, we've been having delays, just as I mentioned. But part of the early naming, I think what was inherited was there was a year that was missed, right, in the drug procurement. Mr. Savali was here, I don't remember which year it was. That particular, sorry?
2014.
2014. So when that 2014 procurement was missed, for reasons probably beyond our comprehension, the subsequent procurement was called, in 2015, was called 2014, right? And then that kept on happening. Now 2016 became called 2015, 2017, 2016, and so on and so forth. So in fact, some time ago we said we need to have an understanding and document this, so that this thing is regularized, so that when we are doing 2022 procurement, we call it 2022 rather than 2021. So the team is looking at that with Ministry of Finance and hopefully with GPPA, so that it's regularized. But that is why we inherited that naming of the procurement, because they didn't believe that you can miss a particular year in procurement. So when 2014, nothing was bought. But when they were buying in 2015, they called it 2014 procurement. And that is what we still inherited, and then it is causing this, you'll be in 2022, and we're talking about 2021 procurement. That's how it started. Yeah, so we hope we can get that regularized. Now, with Ndeban, our sincere apologies to yourself and whoever went there and underwent such treatment. It's not acceptable. It's just not acceptable, but it still brings us to the issue of attitude. And attitude has to be addressed everywhere in the country, more so in the health sector. But we are up to the task, and inshallah it will change. It will change. We have strategies to make it change, because the people who are sick and their relatives, I think what they expect is attention and compassion. But what we also say, which we will deal with, but I give Edward Francis, for example, as an example. If you look at the structure, if you go to the emergency wing of Edward Francis, administratively, for example, the ward has a ward in charge. then the whole deputy ward in charge. The whole unit has a deputy departmental matron. It has a departmental matron. The hospital has 2 deputy chief matrons and a chief matron. Now, that is on the nursing side, who they administer, they are the administrators of the ward and so on. Now, you go to who should make the place clean. You have an orderly, or you have orderlies. They are under the domestic supervisors unit, but there is a chief orderly, deputy chief orderly. There is a deputy domestic supervisor. There is a domestic supervisor. Now you have an infection control officer attached to that ward. Then you come and have the maintenance unit. The maintenance unit for Edward Francis, for example, I think is all close to 50 people. You have carpenters, you have masons, you have electricians, you have plumbers, you have painters, bigger than some factories. Now you have a deputy maintenance manager, a maintenance manager. Now you go to the admin side, you have the operations manager, deputy operations manager. You go to the co-admin, you have director of administration, deputy chief medical director, chief medical director. How come an A&E would not function? And each and every one of these people has a responsibility to make sure that that place is clean, the toilets are good, the light is on, patients are seen. The numbers I named are probably up to 15 or 20. So really, problems are in some of the systems. Well, we will deal with them. We promise that people have to do their work, what they are being paid for, for the people of this country, inshallah. Thank you. So the community ambulances, you mentioned, the community ambulances, I think it's a very important thing.
Yeah, sorry, before you get to the community ambulance, I think you have a follow-up question regarding the...
Yes, no, just to say, during the presentation, just to wrap up, a lot of training is made, but I haven't seen the health promotion training in the National Assembly, and this National Assembly is well listening in the training, and they can also send your messages. I think that was an oversight from the health promotion aspect. You have a lot of training, but this August garden here, the National Assembly was left behind.
Yeah, the minister will take it up.
Okay, we will take it up.
Okay.
So the ambulance is, well, first of all, we started from somewhere. There was none at all. And your comment is noted in the sense that people used to go to health facilities on donkey carts. Women narrated issues to me. In fact, all those contributed to His Excellency bringing up this community ambulance team. There was a woman who was in labor on a donkey cart around Kerado. Now, they was being accompanied by a community but companion. Now, midway between, at night, they got attacked by wolves. Wolves crisscrossing their roads, wolves crisscrossing, they couldn't go. So they had to go back, and the woman delivered at home. Another one was in Nauleru, a similar thing. This now was a horse cart. The wolves sprang into action, wanting to grab them, a pregnant woman on top of a horse cart. The horse itself was so afraid, I was told, it was running at full speed until they reached the main road when the wolves went back. This is what had been happening, and we thought this shouldn't continue. There should be these community ambulances. Now, but of course they are not enough. And our goal is to get more and more, each community virtually getting its own, so that it's standing there. So when we come for support for more community ambulances, inshallah, you will support that. So the payments now, they've been paid. They've gotten their salaries. I think the challenge, that's what I've been informed. The challenge had been that I think there were communication gaps. Some of them, when they just got appointed, they didn't submit any detail. They just started to work rather than submitting their bank details, their ID cards, their TIN, the tax identification numbers, and so on. But of course, at some point, we did tell our people, if they didn't know, it's your responsibility to alert them as to what to submit. But we are told that they have been paid now, and they are working. With regards to the fuel, no community should buy fuel in these ambulances. Why they are doing it, I don't know, but we will find out, we'll investigate, and the practice will stop. These fuel, they are supposed to be fuel from the Ministry of Health budget. Yes, the riders, the COVID funds were being used to fund, but they can find an alternative way of funding it. I mean, they should do that. So no community should buy fuel. That is the message. So wherever they are doing it, it will stop. Sure.
Thank you.
Thank you so much.
Yes, thank you.
Honorable applies. Oh, you have additional?
Yeah,
Yes.
just one.
Thank you very much.
Thank you very much, Honorable, for really highlighting an issue with regards to capacity strengthening. We all know, we're just into our activities with the National Assembly, and the rest also we have a lot of trainings for the National Assembly. We're not only training, but also to put you through some of the international instruments and protocols for you to be aware of, so that when you go to international meetings, you have these protocols and push the agenda of the health sector. One of them is the Ouagadougou Declaration, which we're going to have a training on you on that, the Tobacco Control Act and the regulation, because some of your other colleagues know about, he's part of our committee. So we have series of training on that one, so that you are aware of what is going on and you can be able to take action. Where you can mobilize resources. Typical example is the Ouagadougou Declaration, which really we always want to put it to the National Assembly, because it has been signed by the speakers of national assemblies of ECOWAS countries, so that they can be able to advocate for at least 2% additional budgetary allocation to the health sector. So every year there will be 2% increase to the health sector's budget. This is a document signed by the members of parliament or the speakers of national assemblies of West Africa, ECOWAS countries and Mauritania and Chad in 2017. We were there with the former chairperson and 2 members of the National Assembly. And this document still has not been implemented, and we are putting up some activities around that, so that we show you that document, we share with you, and also you can be able to use that and advocate. Knowing that our role is also to advocate and to work with you in partnership, to be able to mobilize resources for the health sector. So a lot of training will come with us as well. Thank you.
Thank you. Yes, Honorable Member for all you do.
Thank you, Honorable Chair. Thank you, Honorable colleagues, Minister and team. Mine is not going to be a question, but it's going to be a comment from what the presenter presented and what the Minister and team have given us. And as a second-term member, we've gone through a lot. You remember the 5th legislature. Was not a member of the committee, but we've been following closely what the committee has been doing with the Ministry of Health. Our role as National Assembly Select Committee is to ensure that we conduct oversight over the ministry. We understand that the former committee, the 5th legislature, have done a lot with the ministry, and this committee here can fall short where the former committee stops. We'll have to push forward to ensure that where they stop, we move forward with the ministry. And one thing I want to add on all the comment that my colleagues make is not going to be business as usual. I know the ministry have been doing a lot of things. You have improved significantly, even though there are a lot of challenges still now. A lot of people are talking about the ministry is not doing this or that. But from us, we understand that you have improved significantly. And then we wanted to encourage you to continue doing that. But notwithstanding, that would not stop us from exercising the role of this committee. And if it got to that extent, the minister, who is the head of the institution, will not be spared, because the assembly will not want to take that risk. We are representatives of the people. When it got to that, we will deal with the minister, and then the minister will deal with any other staff who is not responding to, his responsibilities under the ministry. That we wanted to make very clear, because a lot has been said, and the National Assembly is looked at as the institution that is supposed to conduct the oversight, take up the responsibility to ensure that the ministry is functioning as expected. So we will take up our role as a committee, and then we expect the minister and team also to take up the responsibility and then move on. So that at least for 2026-27, once we finish this legislature, at least a progressive report will be highlighted, that the people will understand that we have moved from at least a level to another level. And I think that is one of the comments I wanted to make from the presentation. Everything is perfect. We have, we've seen a lot of significant improvement in terms of, promotion, you know, all the things that you have attended to. And I think you will improve on this. We recommend that the effort that you are, you know, doing in the ministry with your team, you keep on, you know, pushing out so that, you know, we can get there. I know the committee will support you in all ways we can. But then we will not also sit and then to say the ministry is not doing what they expected to do, and then we just sit and fold our hands to say, I mean, because there is no funds or there is no that, we will have to make sure that we hold the minister accountable, and then the minister will hold any other staff, being a director or any junior staff, accountable for their respective, you know, responsibilities in the ministry. Thank you.
Thank you very much, Honorable Nembul. That was definitely going to be part of my concluding remark. It's something which you know that, yeah. Okay, I'll come to you. It's something which you know that, Honorable Minister, a lot have been said and a lot is being said, but the work is between you and us. And as he mentioned, the previous committee achieved a lot. In fact, we are rated as, personally I will say, we are rated as the best committee in the previous legislature. And definitely we wouldn't sit down here again to retard or go back in that step. We have to move ahead. We have to move forward, because there was that very, very formidable team in the last legislature. But I believe also there is this formidable team in this legislature. And then I believe, as the Honorable Minister used to do, and his team, they will definitely be ready and then cooperate in working with us. Remember, we are very powerful. This is the second arm of government. We have all what it takes to summon anybody here, but I think we wouldn't do it to that level, honestly. And I know Minister, we've worked with him. He's definitely somebody who know that who is very, very hardworking, who is very, very committed to the welfare of the citizens with regards to health service delivery. But as the Honorable said, this is a team, and in a team, the team have to work together. If the team is definitely not working together, definitely there will be gaps. But I know we'll be there, inshallah. Yes, Director, you have something?
Yeah, just to clear the sniper thing, just briefly, because I think it's genuine that we need to update. Currently, as the Minister said, we already we are working with the stakeholders, with FSGA and the others. So we ship the sample to Senegal, at Lacostock laboratory, and we are expecting the results to arrive by probably next week. And we already have a draft report, and then the final report will come out very soon. Thank you.
Okay. So you already have a draft report, and
yes.
We are still waiting. Remember the resolutions of the last meeting?
Last time we were here.
If it now pass next week, we will call you back again.
No problem. You will get me.
Yes, Honorable Member for Konyi.
You always
Thank you.
Okay, Assalamu alaikum. Thank you so much, Honorable Minister and the team, PS. I'm very happy. Your presentation is very nice and educative. It tells us well, and we know that you people are really hard workers. And we are trying very hard to change the Gambia. But to satisfy human beings is always very difficult. And I have a question here, because I learned at the month of May that some of your staff were on sit-down strike. I really want to know what is the reason behind that. Please, Honorable.
Honorable, I think, Honorable, thank you very much for going for that. I think that's an issue that we will definitely discuss once we are ready with questioning on issues about the presentation.
I want you to
tell you now.
I know what is the reason.
I think you could have definitely updated us. I just beg on your indulgence to allow you to come on the evening so that they can update us. Yes. Yes. You can still do that. Vice Honorable.
Good. Is it afternoon? Huh? Good afternoon, Honorable Minister and team, for that wonderful presentation. My question here goes to: how do you provide private health care to the communities around the Gambia, and it is based on number of people living in an area or the distance between the one health center to another? And the other question is like, is there any plan for the Minister of Health in providing the staffs or nurses around the hospitals or health centers? Because I come from Fonyi, I'm the member of Fonyi Bondali. in my district I have 2 health centers. The other one I don't know whether is private or government, but this week I plan to go and visit those areas. But the one that I know is under the government is Moyok. We have there only one nurse, which obviously, it's very difficult for one to do the entire job there. And then the other thing is, for your expansion, I had the various places you planning to mention or expand rather, but I did not hear any area in Fonyi where you plan, where is under your plan for expansion. Thank you.
Very good observation.
Yes, thank you very much. But I will come to your own when the OB. Yes, so primary healthcare, we believe, should be at the center of the health system strategy in dealing with healthcare issues in the country. So there is a primary healthcare revitalization plan, isn't it? Yeah, so in that revitalization plan, we have the steps that are there. But just as my colleague said earlier, primary healthcare now, they run circuit systems. You have people, healthcare workers assigned to oversee various villages. So you have the primary healthcare core villages and you have other villages. But I think our strategy now is for everybody, every village now in this country to have a trained community health worker in every village. Because we are seeing that in some countries whereby families are attached to a doctor or a healthcare worker. So that healthcare worker has the details, all the health details of that family and monitors them, and they go for regular checkups. If he or she doesn't see the people, he goes to look for them. So, but that way, and then I think mortality and morbidity have actually decreased a lot in those countries, and that's our strategy. So primary healthcare is one of our main tools to achieve universal health coverage, and we're working on that, and it is part of our expansion program. Now,
sorry.
Yes.
For that reason, you know why I asked about whether you do it based on number.
Yes.
Because there's a place in my constituency which is Bambara, Kankurang, and other places.
Yes.
These people are very large community.
Yes.
And then the distance from Bambara to Bondali, where the health center is, is around 8 or 9 kilometers.
Yes.
It's a very long distance.
Yes. So we will note that. But there are various factors that go into location of health facilities. The distance is one. The number is also one. The number, the size, and so on and so forth, right? But we put in a lot of factors but we can note these communities to see what is happening. Now, with regards to Ifonyi, there is a list of health posts that are going to be built. There are 13 in number. At least I know there is one in Fonyi. At least I remember that location, Bulengat, yes, is in your constituency. Yeah. So you remember? You see, I remember his name. Yeah. So your predecessor was very passionate about that. But as governance is a continuity, so you continue with that now. So inshallah, is going to get a health facility, right? And then others are also going to be there. But I don't remember the names of the others. But this one we were working very closely to get it established.
Yeah. Thank you very much. In fact, with regards to the new health centers and health facilities that you intend to construct, please, if you can provide us with the list and this list and there are various of them, that will definitely help. Yeah, that will definitely help. Yes. And then I will encourage honorable members to also engage the minister. His doors are always open, honestly, I can tell you. To always engage him on issues of your constituencies. It's very, very important. Because I know health issue, if you're not here, even at the plenary, if you mention it, everybody will support you. That's not a hidden secret. So definitely, and I know his team, him and his team, their doors are always open. All these directors, anywhere you go, definitely, they will always welcome you because they know definitely what we are here for. Because we are always collaborating with you. So thank you very much. Unless Honorable Yamina is...
Yes. Thank you very much, Honorable Chair. And thank you, Honorable Minister and the team.
I have a follow-up question with regards to Honorable Dabo's question about our traditional healers. As a ministry, what is your take? What do you plan? Because I think our people are lacking one vital thing, which is information. Do you have any plan in establishing radio stations, like a nationwide radio stations, where you tell people these traditional healers, the hazard they cause in society? Yes, that's my question.
Thank you very much. Part of what we mentioned in relation to that was Ministry's been looking at it, and regulating them is not so straightforward. The Medicines Control Act, as Mr. Sabali said, actually is able to deal with those. We know whatever we do should be within the framework, the ambits of the what is feasible, right? What the laws allow us to do. So there is a traditional medicines unit in the Ministry of Health that coordinates their activities for the time being. But I think we need probably some amendments, some adjustments.
Do they have any budget for their activities?
Yeah, so they also have a vibrant association, but even that they have an association of traditional practitioners. They do, and
sorry, please order. Order. If you want the floor, you can always get it, please. I heard your question. He's talking about whether the traditional medicine unit is being budgeted.
Oh, okay, budget. Okay, so
yeah, actually, you know, these are units that are under the Office of the Director of Health Services, and in the budget there is an allocation for regional health facilities, and also in terms of their operating costs, it is the budget monthly allocation of the ministry itself, because the administrative and the operating costs of the facilities fall under the strategy policy, which is under the Ministry of Health. However, this allocation is just for the operating cost. For example, if they have an office that they are renting, we pay for their rent, and that's happening right now. Where their house, their rent is being paid. If they have utility bills, it's being paid. If the staff is there in the unit need, for example, a laptop or stationery, occasionally we supply them to the normal system, even though the amount is limited. But for programmatic interventions, mainly they get their support from partner activities. For example, I'm aware they do some sensitizations, and that is supported by, some of their activities are supported by WAHO will support me, and WHO support their so their operational requirements are funded from the normal ministries or allocation. That's what happens. So these units, you know, they are captured in the budget in terms of their operating costs. In terms of programmatic interventions, mainly that is from the partners.
Yes, directly.
I just want to ask one question.
Okay.
Yes, I just want to have the point to him that wouldn't it be necessary, like when you have a separate entity budget line for this particular important unit of the ministry, where, you know, anytime within the year they need to carry out an activity, they can make a request to your office, and you request
for this particular
for them to be for them to be visible, and you know,
so
executing their functions.
Yeah, so that's the challenge they have been highlighting. One of it is the legislative challenge. The activities they identify mainly are at the moment, because they cannot close anybody's any practitioner. You know, at the moment they don't have those legislation. What they can do is to try to organize them in groups, whereby they have some few operational guidelines that they can give them, but those ones, it's left to the question of whether those can be mandatorily enforceable on them because of the lack of legislation for their practice. But they do sensitization activities, so most of those are funded by the partners, and where they need operational costs, they request, of course, from the ministry, and we facilitate. Even if they sometimes have workshops, we do facilitate and pay for them. We take care of their rent. But definitely, to be able to get an outstanding budget, it means they have to be on full-blown activities to be able to get that.
So just to complement that, honorable member, so it's the unit is like a program. It's one programmatic area, just like so many others we have. So if we want to think in that line, which is a good thing, to empower each of these programs, so that they have a standalone thing that that their activities will fit in. Of course, it means more funding. That's just the implication, and it will enhance efficiency of all the units. And I strongly support that. But the funding implication is the challenge now. Even all the various directorates, because it is, so to say, centralized. Something comes and then it is shared amongst them. A unit wants furniture, they prioritize, and next month another unit gets it, and things like that. So these are the budgetary challenges, but subsequently it can be looked into, so that the budget entities who put in what, Jibril and Co will be able to get the support of finance to say this is for this unit, and it will enhance implementation rather than putting everything together. Because everything is put together under a ceiling now, then that distribution becomes a challenge. Yeah. So, but with the traditional medicine, the other challenge is, of course, we have these challenges, but I think under the Health Services Act, there are provisions that guide the control of individuals whose practice pose a risk to the health of the people, and then the Public Health Act equally. So those provisions can be used for the time being to deal with them, honorable member. But I think generally speaking, what we inherited, even the orthodox health facilities, we didn't inherit any registration process for them. So all these health centers, health facilities, private facilities you see, there's no registration format for them with the Ministry of Health. And we thought that is not acceptable. So we have now brought in people who we had workshops, and then brought in the practitioners themselves, and then the team. So we put in forward a licensing regime for all health facilities in this country, private ones, so that, and then equally speaking, annual registration, annual licensing fee, registration and annual licensing fee.
Okay.
Thank you.
You want to say something? Just briefly, because
no,
time is not on our side.
That's what I was so honorable, that the ministry doesn't have intent to have the radio station, but at least we are also using the existing radio station.
I understand.
Yeah, so, and then we have, we have 10 community radio stations. The other one is in Nyomi, it's not, we are not seeing as, it should have been 11th one, but now that is privately owned. But that community radio station, we have 2 already in CRR South, one in Bitamba and one in Bansang. So what we do, when we have activities, we get the traditional healers themselves, we have activities with them, we also allow the platform for them to be able to share their experiences. Like also advising other people who are also going beyond their limits. So we've been doing a lot of activities in the sensitization. So when we have training, we include traditional healers. Like when we say we want traditional communicators, we also have participants coming from traditional healers within the region or within the district. We also invite other local authorities. So we normally combine trainings. When we have training, we combine the instructors. So when they also go out, they also talk to the other people in addition to radio programs. That's what we are doing. But at least we want to improve on that, inshallah.
Yes, I understand, but I know in this country, like the information is lacking, because if you are to analyze, very high percentage of Gambians listen to radios.
Yes, that's true. 95.
And yes, and I believe the ministry should also have their private radio where you refer yourself when you want to know something about the health. Like most Gambians don't know what diabetes, TB, and etc. They don't know what they are. I was shocked when I heard the statistics of HIV/AIDS not long ago. Thank you.
Yes, thank you very much, Honorable. I think that will serve as a recommendation.
Yes, but I have a point to that, and it's just in, if I may.
Yes, this time.
It's just in agreement with you. I think we need to come out, and I've been saying it myself, but we have strategies to do that. We want to use prime time, radio and television prime time to get health messages across. It is something that we are passionate about. Midway during the news, or just before the news commences, we bring out something that causes hypertension in women. Everybody's watching. Then we know, oh, so when you see this is what it means. So we have plans for that. I totally agree with you. So we are strengthening our communication strategy, and we want to actually modify, build on some of them, but modify and be innovative in our communication strategy. Thank you.
Thank you.
Yes, thank you.
Yes, Honorable Vice Chair, you have something?
Thank you very much, Honorable Chair. First of all, I will want to seize this opportunity to commend the Minister, the PS present here, and also all the directors, and my fellow honorable members for at least making sure that all the questions that are asked are very important and of relevance. But I just want us to understand one thing as far as health is concerned, which is also one of the key tools when it comes to harnessing demographic dividend. And understanding that Gambia is youthfully populated, and looking at the situation, it's like they are the most vulnerable, more especially the youth and the women. And a better understanding that health is very important. That is why part of the 17th Sustainable Development Goal, it is also considered as SDG 3, which is very key. We also talk about our welfare and or our well-being. So in doing so, I will first of all start by saying that through the presentation, you did mention so many important things in terms of how far the ministry have gone, in terms of at least improving the healthcare system of this country, which is very key and also very important. But looking at it also, there are challenges attached, which we believe as honorable members, we see ourselves as problem solvers as far as our collaboration is concerned with the ministry, because this committee is very important in making sure that the healthcare system of this country is up to date and is up to that standard. But in doing so, I have some questions that has to do with, during the presentation by the gentleman over there, that has to do with the inauguration of 5 new health facilities or posts in this country. I would just want to know where the inauguration took place, and so that other members will know. One other thing, I will also join my honorable member, that is Honorable Baji, being biased to ask, because looking at the dump site in Banjul, is located at Banjul North. Looking also when it comes to the amount of health hazard that it is really costing to the people of Banjul, more specifically Banjul North. What is the Directorate of Public Health doing in terms of making sure that either it is relocated or to collaborate with the City Council and see how best they can fence the area? Because I understand that most of the things that is dumped or disposed there comes from the hospital, which is very important, and it is a big concern, I can tell you, to the people of Banjul, and to be specific, the people of Banjul North. The issue of emergency. We now realize that the emergency unit have been transferred to Nemba. Understanding the health implication that sometimes occur as scenarios within the city of Banjul. We have to take a car to Demban. In some occasions, you will come to realize that people sometimes might pass away on our way going to Demban, because I've been involved in so many scenarios whereby we have to take a patient, more especially these asthma patients, and there is a situation whereby one of them passed away on our way going to Demban, and we want to know why is it not possible. We understand that renovation is going on as far as the main referral hospital is concerned, which is very important, because like I said, there is always room for improvement, and also making sure that we reach that standard in terms of our healthcare system. But in doing so, I just want to seize the opportunity to appeal to the minister to at least have a unit or a building within the city whereby we can have at least emergency healthcare system, so that our people can have access to emergency care as far as their emergency health situation is concerned. Another thing has to do with the availability of the sanitarium. I understand the sanitarium was used for TB patients, then later on renovated for COVID-19 patients, which is very important. I don't know whether, to be honest, whether they are still using that place. Looking at the situation of COVID in this country now, and also the severeness of COVID in this country now. If not, I will also seize this opportunity to appeal to the minister and team that if they can even use it as an emergency center for the people of Banjul in terms of having access to primary health care. Another concern that I have has to do with the hinterland of this country, because even though I was born and raised up in Banjul, my parents are from the hinterland. And I normally do go and visit the village in a very, I do it always, to be honest, because I just love to be connected with my people, more especially the life that they have over there. But looking at the situation over there, like the honorable member have said, we still have women that deliver on their way going to hospitals. And one of the recommendations that I think I can share with the team here is that I think it is very important to introduce a mobile clinic. Why I am saying this, I heard the minister talking about 80 ambulances being provided, but are they well-equipped ambulances? Because when you talk about ambulance, the expectation is so high as far as the healthcare system of this country is concerned. Because no matter what, as a patient, you can at least have a first aid treatment before even reaching to the hospital. Are we also considering that? Do we have ambulances that are well equipped in terms of making sure that we attend patients even before reaching to the hospital? And this is happening in other countries. And I believe it is also something that we really have to consider in making sure that it happens. I know it will involve a lot of resources, but at the end of the day, the primary concern as far as we are all together in this is to make sure that we make sure everything is provided. I also had the issue of the sniper that the results have been, let's say the samples we are taken to other countries to do the testing, and it will be sent back to the country, or the result will be sent back to the country, so that the Department of Public Health, in collaboration with Food and Safety, will come publicly and tell the people what is really going on. I did mention it during our engagement with them, that it is high time, and we really have to consider it this as a nation, that it is high time for us to start doing this in this country. We must create the labs. We must make sure that we have the experts to make sure that they do all the necessary testing in this country. The world is advancing. And in any development situation, we must do it together. We should not leave anybody behind. And I think this is very important, that for us to start considering this. I know always people will talk about, yes, the availability of resources. That's true. But also we have to prioritize and see some of these things start happening in this country. Because I heard the Honorable Minister talking about some of these surgery processes that they want to bring to the Gambia. Specialists that they want to bring to this country, which is very important. This is the way forward as far as this country is concerned. The number of doctors, I personally want to see the number increasing. I want to see more doctors in this country. But how can we do that? We have to come as a nation, as a team, to make sure that all these things are put in place. So, in other words, we are politicians, but we are also honorable members. In order to make sure that everything is in order, we must say what we feel and what we think it is very important, because our main function here is to make sure that we address the needs and the concerns of the people. And when I am speaking, I always speak based on what the people say outside there, because that is more important as far as I am concerned. All of us are not feeling well, to be honest. In one way or the other, we are physically challenged or we are differently able. But in other words, at least we have that amount of energy to sit down here and talk to the people. And I believe it is always important to do justice in whatever we do in terms of addressing issues, more especially health issues. I don't know for any other thing, but as far as health is concerned, in this country, I believe the entire team, that is the honorable members, are ready to make sure that we collaborate with the ministry and make sure that we do what is expected. The raining season is already on, I can say. I can remember when I was at the City Council, collaborated with the Public Health Service unit of the ministry, and we conducted fumigation exercise in the city of Banjul. I am appealing to you again, Honorable Minister, with your team, as soon as possible to come up with such an initiative. Because it is very important, the people of Banjul are in need of it. There is a lot of mosquitoes and other insects that are really coming out nowadays that we don't understand, and we believe it is high time, more especially my constituency, because we are next to the Tangbi wetland. And you can see the amount of mosquitoes that we encounter. I don't even say per night, but per day. Even inside this hall, you can see the existence of mosquitoes. They are around. So I believe it is also very important for us to collaborate and make sure that this happens as soon as possible, so that we can at least mitigate or mainstream some of these issues that has to do with mosquitoes within our community. So thank you very much, Mr. Chair.
Thank you very much, Honorable. Thank you very much.
Thank you very much.
Thank you very much, Honorable Minister.
Thank you very much.
There are a lot of comments, but
yes,
you can just
yes, I will just, thank you very much. With regards to the facilities that were inaugurated, there was one in Tampoto, Kony. There are two in Brikama, one in Brikama, Wellingara, the other Brikama and Nyambai. And then there is one in Makumbaya and Kusumba. Yeah, so those are the facilities that were inaugurated, and each of them was given a community ambulance just after during the inauguration. Yes, as you rightly said, quite a lot has been achieved, but there are a lot of challenges still, because it's nation building. Gambia is a developing country, and the health sector is also going along with the development, and we thank you for all the support. With the dump at the dump site in Banjul, it's a big challenge. At some point, the Director of Public Health can comment, but I think we've noticed the challenge, especially for the medical waste. Well, honorable member, distinguished honorable members, we are happy that we are handling the clinical waste now. Just as I mentioned earlier, EFSTH has a big clinical waste management team now. So it uses the latest technology, it's a microwave technology. So clinical waste now are, so to say, going to be sterilized. Wherever you put them, in fact, they are not going to be hazardous. Some people are even thinking of using it as manure, isn't it? Or other what comes out, compost, because it is now sterilized, and they are actually organic materials, most of them. The bigger one is now in in Farato. That's the Ecosterial 250, the one in EFSTH. We insisted on putting it here because EFSTH is the biggest hospital that produces most of the waste. It was a big debate trying to convince the team to put that in EFSTH, but it is now here. So that means now waste from EFSTH will not be going there. So it will be domestic waste, which is easier to handle. And we totally agree because clinical waste sent there and the rain washes it into the water bodies, we've been concerned. But this is what we inherited since independence time, but now we are able to deal with clinical waste in this country. And the regions, each health region, each of the 7 health regions has a big incinerator. They are already here. In fact, they are operating as we speak to you. So I think there's a big plus. And in addition to having the clinical waste treatment center, we have 3 waste collection trucks. Very interesting, very big plus. And these are covered, and they are, so to say, refrigerated, so that even whatever is in them doesn't ferment, because sometimes body tissues are there, and they are already in country. And they are now going to go to all the facilities, including private facilities, to collect waste and take it to the dump site, the site in Farato. Why that is also equally important is the fact that we now have commercial waste collectors who go to clinics, health facilities, and so on. They hire trucks, go to health facilities, they pay them a fee, and they mix the clinical waste with the domestic waste and carry it in trucks that they hired. And those are the same trucks that another person will hire to take rice or to take oil and so on. We thought as a country that is very risky, so we added provision of trucks in this thing, and all the trucks are already here, and they'll all belong together sometime next month, inshallah.
Says if you attack by the private health facilities.
Sorry, sir.
Sorry. I think definitely these are issues that continues to pop up.
Yes.
But like just focus on the subject that he asked you, and then I think you have responded. Unless if he's not satisfied.
Okay.
You understand? Then we move on to the next, because definitely we are already
we are running out of time.
Another committee is supposed to occupy.
Oh, okay. So we'll be very fast. So the emergency wing is a temporary arrangement. That is why it is in Deban, to give Banjul the facelift that it deserves, and the hospital. But you are right, if we are having challenges, we'll look into that. We'll look at where we can have space, either the sanatorium or the polyclinic, which is tight now, or EFSTH, where emergencies could be seen for people in Banjul, where they can be stabilized, right?
I think that is very important. Yes, you can act on it immediately.
Yes, so the team is here, they are picking it up, and then we will look into that as a matter of urgency. Now, so with regards to the women delivering on the roads, we are trying our best. That's why we expanded the health infrastructure, so that the distances they have to travel will be shorter. And that's why we provided the community ambulances, and we hope to do more and more of that. Of course, the challenges are, health sector, there are a lot of factors that are not within the sector. The road network, if the road networks are good, probably they'll even get to the facilities earlier. But as we are developing, we'll put our hands all together on the same deck so that we can get to where we need to get to.
Yeah. But don't forget, Mr. Chair.
Yes.
Don't forget also.
Yes.
I talk about the issue of mobile clinic.
Yes.
Making sure that the ambulances are well equipped.
That's correct. So the ambulances are equipped. What we can do in various ambulances, there is the basic life support, and then the advanced life support to the extreme end. Even in the West, certain ambulances can do certain things, but there are basic things that people should be able to do, health workers should be able to do for a patient on transit. Of course, every system has its limitation. This has their limitation. The COVID ambulances are able to do the advanced life support, and there are 10 of them, COVID ambulances. These 80 community ambulances have first aid kits in them. There is a long box in each of them, and it has first aid kits, so the people are trained to do the basic life support. But I think it's also very important for us to let the honorable members know that currently we are also looking at an emergency response system for this country. We started the work, and the Turkish government has trained quite a lot of Gambian health professionals in preparation for that. And what we want to do is along the highways, the southern bank and the northern bank, we want to put ambulance spots, especially a lot of places around the Fonyi where you have all those accidents. There's a part in Fonyi that's very prone to accident. So it's going to get an ambulance spot. So these are going to be run by paramedics, and they'll be there 24 hours. We have designed all. In fact, we were waiting for funding to construct those sites along the highways. Now, so that when there's an accident, they become the first responders. We have even identified the villages or towns where they are going to be, and as we get more and more funds and as the country develops, we'll be putting in between them to shorten the gaps. So that is on the way, so for emergency response. In a similar vein, we also, on the same highways again, we are getting what we also call rest areas in our WASH strategy to eradicate open defecation. Gambia has gone very far in our attempts to eradicate open defecation in the country, and countries are commending us for that. But to get an open defecation-free society, we believe there should be rest areas on the highways. So we are putting forward, I think, 13 of them, which will have toilets for male and female and a restroom, and even a coffee room should be there. We designed it so that when people are traveling along the highway, they can take a break, use the bathroom, and then have a cup of coffee. So that's also coming on. So a lot is coming. Now, with regards to the sniper issue, so with regards to the laboratories, we also inherited a very difficult situation. I will just use one sentence to say this. Very difficult situation. But WAPO, South African Health Organization, we engage them to help us have a drug lab in this country and a food lab. We're pushing that engagement. And finally, for your information, honorable members, we are very excited that oxygen has been a problem for many countries, especially during COVID. We have now gotten a brand new oxygen plant at Deban that is given to us in partnership with the Turkish government. And we are expecting 3 more. So now we're going to be producing even more oxygen than we can consume in the health sector. So this one, they are testing it now at Deban. And then equally, the fumigation machines that he spoke about, that used to be in Banjul when we were children, and we used to see them spraying Banjul and all environs. Together with our collaboration with partners, Global Fund and Rotary, we have as a country 3 of them now to be fumigating the entire country. So that is the thing.
Thank you very much, Honorable. We wish we can continue the engagement. You know, we also belong to others. That is not addressed. That is the question asked by the Honorable Member for Fonyi benefits. That is the issue of strike by, it says by certificate. Can you please answer that question?
No, that they are on sit-down strike.
Okay.
Yeah, they were on sit-down strike. We can get notice. What's the reason behind it?
Yes, thank you very much. Some of them are on strike. I'm told some are working. That's the public health officials, public and environmental health officers. Striking on the basis of not having received allowances. These are allowance increments that they have requested for. So they are currently receiving all allowances that they are entitled to as employees. But when we embark on allowance increments, because we believe health workers need to be remunerated well. The health work is very difficult, risky, demanding, and so on. So we thought to motivate, health workers need to be motivated. So when they're in the health facilities, they can focus on their work, which is, life-saving work. So this allowance issue started, and then the plan had been to pay everybody at once. But that had been difficult because of the budgetary challenges, from the Ministry of Finance when we engaged them. It was being done in phases, and then the nurses had gotten their own. And those adjustments too, we had said the other health workers would get. Public health officers, public and environmental health workers, the pharmacists, the physiotherapists, radiotherapists, and so on and so forth. So all that have been worked out and finalized. But it didn't, these things involve various stakeholders. Ministry of Health has the vision, has the intention, but we go along with the Personnel Management Office, we go along with the Ministry of Finance that makes the availability of the funds. Various discussions were held, and at some point we reached a level whereby we thought everything was even ready because there was approval of this at the level of cabinet. Cabinet also supported it. The executive supports it so very well. Now, as we went by, we were even thinking of now, how do we fund this? But at some point, it was realized that this was not in the budget, because last year the budget session, you remember, was done earlier. We were told because of the elections, and the approval was in October. So before this was completed, the budget was done. Now that was brought to the attention, to our attention, Ministry of Health, Ministry of Finance, and the PMO, and so on. So we said, even if potentially there are some resources lying down, it will be difficult to pay this immediately. It has to be, because we want to institutionalize it, because it's not a one-off allowance, it's a continuous allowance that needs to be paid continuously. So the suggestion came that why doesn't Ministry of Finance look at it, at Ministry of Health, we look at how it can be funded. All the calculations have been done. But the Ministry of Finance, so before then, they were promised that it would have been done by the end of May. That was the intention. And everybody was ready for that, but these things were flagged out, that to make it, to institutionalize it, we have to follow procedure. And that procedure now, Ministry of Finance said they are coming to the Assembly very soon, this month actually. Yes. For the supplementary. So because they are coming in, they said the advice is, why don't we put it, why don't we wait for them to bring it here so that there can be an appropriation for these allowances to be paid, so that to have it on a solid basis. And I think we all agree with that, because in as much as we want to pay.
Sorry, Honorable Davo.
Yes.
Please allow him to land.
It's your friend. Yeah. So we say that's the idea, that it comes to Parliament. Now Parliament now deliberates on this and appropriates this for this purpose. Then we can be acting, I believe, within law, isn't it? So that is it. That is because it was not put in the former budget. But we said, in fact, it's an opportunity, and it is this month. So we had wanted them to come to work, but we believe sometimes they are not getting the messages. Sometimes, of course, unfortunately, it is sad that some people bring other sentiments in health issues, and we believe health issues, we should keep other sentiments out. As a country, we are all one people. We want the best for our people, and so really, health worker strike is very unfortunate. Because as a health professional, when I was much younger, I never ever dreamt of abandoning, laying down my tools for whatever reason, because of the people that we care so much about. So our appeal is for them to go back to work, because it's being worked out. Thank you.
Thank you. I think that is definitely.
Minister,
thank you very much. In fact, we are into the time of the other committee. This is an issue which you know that is definitely a bit disturbing, because I know there are certain health workers who are not going to work due to this issue. But as a responsible ministry, we are lawmakers, and you know our doors are always open. If you have issues of challenges, whereas you need our support, please come to us so that we can iron out these things to find a way forward. Because definitely the last people that should be engaged on strike, as far as service delivery is concerned, is health workers. It's not helping, and it is definitely affecting our own people that we represent here. So do all it takes and engage us wherever that you think it is definitely necessary for us to resolve this issue. And then definitely by way of resolution or by way of recommendation, please, if you go back, engage this particular leader, discuss them, brief them, update them about this issue, and I think they should be definitely contented with this, and then we move on. Because as you mentioned, there is always something very, very strong and solid and strongly put that is there for them. And I think if they listen to this, definitely they will be listening. And I know it's just a matter of sometimes miscommunication here and there, but let's just keep up the work, the good work that we are doing, and we continue consulting, we continue engaging. Our doors are always open. So thank you very much. On that note, I just want to thank everybody, especially the minister and team, and also honorable members for making us it in the other committees time. And I know because this is about it's about health. Everybody's interested. I wish we can continue more, but unfortunately we have to stop there. Stop here, and then we adjourn the meeting until another time. The meeting is now.